Yes. Yes, guys. We'll start with the. Oh, yes. We'll start with the last resort revision for FMGE. Okay. We'll go question wise. Okay. Starting with the first question, guys. A 40-year-old, right? A 40-year-old cirrhotic patient requires muscle relaxation for surgery. Which muscle relaxant is regarded as the safest? Come on, guys. He's asking about which muscle relaxant is safest in patient who's undergoing or in patient who's cirrhotic patient who's undergoing surgery. Okay. So which muscle relaxant is safest, guys? A. Vecuronium, B. Pancuronium, C. Atracurium, and D. Rocuronium. Guys, just look over here. The answer over here is basically we need to choose a muscle relaxant that has nothing to do with the kidney, that had nothing to do with the liver, which is not metabolized in the liver. There is only one muscle relaxant, or there are only two muscle relaxants that are not metabolized in the liver, which undergoes Hoffman degradation. What are those muscle relaxants? Atracurium and cisatracurium. They undergo a magical metabolism, which is called as Hoffman degradation or Hoffman elimination. Okay. Now discussing something about muscle relaxation. Guys, just look over here. Muscle relaxants are divided into two categories. One are called as non-depolarizing, other is called as depolarizing muscle relaxant. But first we are discussing about the non-depolarizing muscle relaxants. Under non-depolarizing, again two categories are there. One is called as benzylisoquinolinium, other is called as steroidal. Benzylisoquinolinium, quinolinium yani ke queen. Okay, queen. So what are the examples of benzylisoquinolinium? Examples are atracurium, cisatracurium. Remember, guys, atracurium and cisatracurium both undergoes Hoffman degradation. Yani they have nothing to do with the liver and kidney, that hence can be given in liver failure or renal failure. Next is mevacurium, which is regarded as the shortest acting muscle relaxant. Next is doxycurium, which is regarded as the longest acting muscle relaxant. Okay, so these are benzylisoquinolinium. Remember, guys, benzylisoquinolinium are the muscle relaxant that will release histamine, which can cause allergic reaction. Benzylisoquinoliniums are the muscle relaxant which will release histamine, which can cause allergic reaction. Now, a small mnemonic to remember this, which is shortest and which is longest, is what, guys? My short dog has long tail. M stands for mevacurium, which is the shortest acting muscle relaxant, and dog has long tail, yani ki D and L. D stands for doxycurium, which is the longest acting muscle relaxant. Okay, these are benzylisoquinolinium. Next is curoniums. In curonium, you are having only three: pancuronium, rockcuronium, and vecuronium. Pan, rock, and vec. Now, regarding pancuronium, remember, guys, pancuronium, when anyone is telling you, you have to remember RRR. RRR was a pan-India movie. RRR movie was a pan-India. Hence, pancuronium means RRR. Why am I telling RRR? Just look over here, guys. R stands for renal. Pancuronium is having maximum renal excretion. Hence, it is contraindicated in renal failure. You cannot give pancuronium in renal failure. Okay. Next, pancuronium rate. Rate means what? It increases the pulse rate and BP. Hence, pancuronium is regarded as muscle relaxant of choice in shock. Muscle relaxant of choice in shock. Last is recovery. If you give pancuronium to the patient, it will take some time for the patient to recover. Patient might not recover in the confined period of time. That is called as delayed recovery. Pancuronium ke saath mein you might see a delayed recovery. Okay. Next, after pancuronium is vecuronium. Guys, remember vecuronium. When we are writing the vecuronium V, always remember the V of vecuronium looks like heart. You can add a heart to that V. Okay? So what does it mean? Vecuronium is the most cardiostable muscle relaxant. It is the most cardiostable muscle relaxant. Okay? But it is excreted through the biliary tract. It is having maximum biliary excretion. Hence, it cannot be given in obstructive jaundice cases. Hence, avoided in obstructive jaundice. Avoided in obstructive jaundice. Okay, that's regarding vecuronium. Last is rocuronium. Guys, remember, cardiostable. Cardiostable meaning what? It won't have any effect on the BP and it neither increases nor decreases. Last is rocuronium. Rocuronium meaning what? Rocuronium is the fastest acting muscle relaxant. Now someone, if you forget what is, remember guys, fastest yani ki onset is fast. So rocuronium starts with the alphabet R and O. That will only tell that it is the fastest. Why? Because R means rapid, O means onset. Rocuronium RO means it is a fastest acting muscle relaxant. Okay. We can also remember rocuronium as a painful rock star. Why? Because it's a painful muscle relaxant. Coming to the next question, guys. Okay. Patient underwent surgery under general anesthesia, was complaining of muscle ache and body ache post-surgery. Which drug is likely attributed to this complication? Come on, guys. What is the drug that causes this complication? After surgery, patient is complaining of muscle pain. Very good. Propofol won't cause any pain. Thiopentone won't cause pain. Midazolam won't cause pain. Scoline will cause. But how, sir? You are just telling that it will cause. But how it will cause, that is important. Remember, guys, scoline is a muscle relaxant. When you give scoline to the patient, muscles should relax. But what will scoline do? As we give scoline, initially the patient, the patient's muscles will contract. Okay, those are called as fasciculation. Rapid contractions you will see in the first 10 to 15 seconds. After 10 to 15 seconds, yani after 20 seconds, the muscles will get relaxed. Due to this rapid fasciculation, the patient complains of muscle pain or muscle soreness. Okay, guys. So that's the answer. Why the patient is having body ache post surgery? It is due to scoline use. Now regarding scoline, देखो भाई class 2.5 hours की होगी, ठीक है? So regarding scoline, what we need to remember, scoline is a depolarizing muscle relaxant which is regarded as the shortest as well as the fastest acting muscle relaxant. It is regarded as the fastest as well as the shortest acting muscle relaxant. Okay, 30 to 45 seconds and onset is and duration is for 3 to 8 minutes. Where is scoline metabolized? By plasma pseudocholinesterase. But in some patients who are having pseudocholinesterase deficiency and you give scoline, what will happen? Basically, remember guys, when pseudocholinesterase is efficient and if it is of good amount in the body, then scoline will act for 3 to 8 minutes. But if there is deficiency, then what will happen? Then the scoline action will prolong for a long time. That leads to a condition called as scoline apnea. Scoline apnea यानी कि after giving scoline, patient should recover in 8 minutes. But if the patient is not recovering even after 20 minutes, then it is called as scoline apnea. Scoline apnea is commonly seen due to deficiency of pseudocholinesterase. ठीक है? कोई दिक्कत नहीं सर, ठीक है. So pseudocholinesterase. Now look over here, guys. How is the scoline apnea? If at all the patient has not recovered, how will you come to know the patient is developed scoline apnea? You will do a test which is called as Dybucane number test. With Dybucane number test, you will come to know patient is having scoline apnea. And how will you treat it, guys? Scoline apnea यानी कि patient is not breathing, just put the patient on mechanical ventilator. Positive pressure ventilation is the main management for scoline apnea. What are the side effects of scoline? It is very simple, guys. Two side effects are common. First is the most common side effect of scoline is muscle soreness that we have already discussed now. And second side effect of scoline is what, guys? It can cause hyperkalemia. Why hyperkalemia? Due to initial fasciculations, the patient might become hyperkalemic. Due to this reason, we usually avoid giving scoline to patients who are already hyperkalemic, such as burns patient or long-term paralysis patient posted for some surgery. We don't give scoline. Why? Because already hyperkalemic. If you give scoline, what will happen? Hyperkalemia worsens and can lead to arrhythmias and cardiac arrest also. Coming to the third question, guys. A child develops... भाई आवाज क्लियर है? ठीक है. A child develops high fever, muscle rigidity, tachycardia and rise in the ETCO2 during surgery under halothane and succinylcholine. What is the first line in management? देखो भाई अच्छे से पढ़ो और इसका आंसर दो. डायरेक्टली जंप मत कर दो कि हाँ भाई हमने ये डायग्नोज कर दिया, अब उसको आंसर दे देंगे कुछ. Come on. What's the answer for this? The answer for this is basically, first of all, what is the patient having over here? A high temperature. Patient, when he is having a high temperature, muscle rigidity, all these are the features of malignant hyperthermia, which is a very important as well as a favorite topic for the boards to ask. Okay? Now in malignant hyperthermia, when it is diagnosed, what is he telling? What is the first step of management? He is asking the first step. He is not asking you the treatment of choice. The treatment of choice is obviously dantrolene sodium, but the first step is what? What are the things which are causing malignant hyperthermia? Those are halothane and succinylcholine. You have to stop the triggering agents. That is the first thing. After stopping the triggering agents, we can cool the patient. We can give IV dantrolene sodium and administer soda bicarb according if the patient is having any acidosis. Regarding malignant hyperthermia, guys, in anesthesia, there are many things that can cause malignant hyperthermia, such as lignocaine can cause malignant hyperthermia. Okay? And in muscle relaxant, it is choline that can cause malignant hyperthermia. Apart from that, inhalational agents, almost all inhalational agents can cause malignant hyperthermia. Maximum risk of malignant hyperthermia is seen with an inhalational agent called as halothane. Okay, something about malignant hyperthermia, what we need to remember, it is commonly seen in autosomal dominant patient. The gene responsible is RYR1 gene. Okay, and once you give succinylcholine to a patient who is autosomal dominant, what will happen? This succinylcholine will go and it will basically stimulate the abnormal ryanodine receptor to produce calcium. As calcium is being produced, patient develops muscle spasm, which is starting in what muscle? Starting in the masseter muscle, thereby whole body gets involved. If malignant hyperthermia occurs, what is the test that we need to give? We need to go for a provocative test, which is called as halothane caffeine test. And if malignant hyperthermia occurs, the treatment of choices, obviously you give IV dantrolene sodium. So there have been one question, what are the channels involved in malignant hyperthermia? This was asked. It's pretty simple. Malignant hyperthermia, the channels which are involved are calcium channels. Okay. Next, which of the following is a contraindication for spinal anesthesia? Come on, guys. In which following condition spinal is never given? Guys, remember the first question, the first option is hypertension. If hypertensive patient is posted, first of all, spinal anesthesia is given for below umbilicus surgery. If hypertensive patient comes for below umbilicus surgery, will you give spinal or not? I can safely give. Why? If his BP is 170/80, I give spinal. BP becomes 120/80. Spinal is known to cause what? Hypotension. When you give spinal to the patient, patient's BP will fall. So it is not a contraindication. Mild anemia is not a contraindication. Diabetes, controlled or uncontrolled, again it is not a contraindication. But if the patient is saying, no, bhai, I don't want spinal anesthesia, that is a contraindication. Even though you say the patient, bhai, spinal is having so much it will have so much ease and all, but still if the patient is saying no, means no. Okay, so what are the contraindications of spinal anesthesia, guys? Patient refusal is a contraindication. Apart from patient refusal, guys, remember, if the patient is in shock, not hypertension. Hypertension is different, shock is different. Both are different entities. If the patient is in shock, never give spinal anesthesia. Patient BP will more fall. Okay? If the patient is having fixed cardiac output lesions, okay, then spinal is contraindicated. Spinal is also contraindicated in local site infection. If at all at L4, L5 space or skin, L3 to L5 skin, if the patient is having some skin infection, don't give spinal anesthesia. Okay? Next, if the patient is having a raised ICP, spinal is contraindicated. If the platelet count is less than 80,000 or INR more than 1.5, spinal is contraindicated. Okay. Next, 60-year-old man receiving epidural bupivacaine, okay, develops convulsions and arrhythmias due to accidental intravascular injection. What is the drug of choice for management? So basically intravascularly you have given bupivacaine. Now how will you manage? Remember guys, bupivacaine is the most cardiotoxic local anesthetic. Never ever should be given intravascular. मिस्टेक से भी ये मिस्टेक मत करो. अगर मिस्टेक हो गई तो प्रॉब्लम होगा. क्या होगा? Patient might develop arrhythmias and might develop cardiac arrest also. But you should know what is the treatment of choice for those patients who accidentally receive this. It is 20% of intralipid solution. 20% intralipid solution. Okay. We'll discuss more about it later. Okay, next. 35-year-old man is undergoing spinal anesthesia for inguinal hernia repair. While the spinal needle is inserted at L3, L4 space, the anesthesiologist feels two pops before clear fluid is seen at the hub. Basically, he's asking what structures are pierced in spinal anesthesia. Okay. Are you able to see, guys, what are the structures pierced in spinal anesthesia? A, B, C, D. What's the option? Basically, remember, guys, basically, if someone asks me structures of spinal anesthesia, I would answer some say spinal instigates lethargy during anesthesia. Okay, some say spinal instigates lethargy during anesthesia. Yani what is the first layer to be pierced? Skin. Next, subcutaneous tissue. Next, supraspinous ligament. Next, interspinous ligament. Next, ligamentum flavum. Next, once you puncture the ligamentum flavum, you will feel a pop. First pop. Okay. First loss of resistance you will feel at ligamentum flavum. Once you pierce ligamentum flavum, there will be a space, epidural space. Then you need to puncture the dura. Once you puncture the dura, arachnoid will be there. Lastly, you puncture the arachnoid, you will be in the subarachnoid space. So I told you the mnemonic is some say spinal instigates lethargy during anesthesia session. Skin, subcutaneous tissue, supraspinous, interspinous, lethargy. L stands for, this is very important, guys, ligamentum flavum, which is regarded as the toughest ligament. On piercing, you will basically feel, I have passed ligamentum flavum. Okay. Why? Because it's the toughest ligament. You will feel a snap or sudden loss of resistance. The second pop you will feel on the puncture of dura. Once dura is punctured, arachnoid will be the last layer. And once you puncture the arachnoid, you will be in the subarachnoid space, which will have the CSF. So last layer to be pierced in spinal is arachnoid. Guys, remember, in epidural, what are the layers pierced? That could be a question. Or they might ask you, what is the last layer pierced in epidural? Guys, remember, epidural means outside the dura. So all structures will be same except the dura. Okay. So once you are in the, going in the epidural space, just look over here. First is what? First is skin. Next, subcutaneous tissue. Next, supraspinous ligament. Next, interspinous ligament. Next, ligamentum flavum. So the last layer to be pierced in epidural is ligamentum flavum. Ligamentum flavum. That is the last layer. Okay. Once you pierce ligamentum flavum, you will be outside dura. That is the epidural space. Next, guys. So the voice is cracking in between. By voice clear hai everyone, please. In between cracking means what? Clear? Okay. Which of the following complication is regarded as the most common intraoperative complication of spinal anesthesia? Come on, guys. Most common intraop complication. Intraop yani ke you have given spinal, and now what complication that is recorded most commonly? I'm not asking about after surgery complication, that is post-op. Most common intraop complication is what, guys? Remember, post-dural puncture headache is a post-op complication nowadays, not seen. Why? Because we are using thin bore needle. Urinary retention is the most common post-op complication of spinal anesthesia. Okay. Now we are left out with hypotension and local anesthetic systemic toxicity. Local anesthetic systemic toxicity is rare unless and until you give the drug in the blood vessel, then only it will happen. What is the most common, guys? The most common is hypotension, right? Why hypotension occurs? Remember, once you give spinal anesthesia, it will produce sympathetic blockade of the lower extremities. Yani ke, if lower extremities are blocked, just look over here, what will happen to the blood vessels? If sympathetic activity is blocked, blood vessels will dilate. All the blood from the upper part pools in the lower extremities. The blood will sit in the lower extremities. Yani ke, what happens to the blood in the upper extremities? Blood volume decreases. What happens to the cardiac output? Decreases. Venous return decreases. What happens to the BP? Decreases. So basically you need to understand, guys, the most common intraop complication of spinal anesthesia is hypotension. Due to this reason, what I do is, even though before giving spinal anesthesia, I prepare an emergency drug tray where I keep the drugs beforehand, so that once complication occurs, I am giving the drug. Okay, so what is that emergency drug tray which I am keeping? I keep phenylephrine, I keep atropine, I keep pethidine and laryngoscope and ET tube and adrenaline also I am keeping. Okay, why am I keeping? Why? Because remember, the most common complication of spinal anesthesia is hypotension, and hypotension is managed by phenylephrine. Okay, second most common complication is what, guys? Bradycardia. Bradycardia is managed by what? Bradycardia. Remember, the most common complication is hypo. Second most is bradycardia, which is managed by atropine. Third is what, guys? Shivering. As the blood is going into the lower extremities, patient might have shivering. So shivering can also be managed with pethidine. That's why the third drug which I have kept is pethidine. Fourth complication is high spinal. High spinal means what? Drug has ascended upward. That is called as high spinal, which is characterized by two things together, hypo and brady together. That is important. These are intra-op complications. ठीक है, ये है इंट्रा-op complications. Okay, post-op complications में क्या होंगे? What is the most common post-op complication of spinal anesthesia? यानी कि after surgery patient complains of urinary retention. The most common post-op complication is urinary retention. Is headache seen nowadays after spinal? No, sir. If I am using a large bore needle, I will see headache. And if that headache occurs after spinal anesthesia, it is called as post-dural puncture headache. How will you manage that post-dural puncture headache? The best management is conservative line of management. That is what? You are giving rest to the patient, you are giving fluid to the patient. But the definitive management is what? Patient is having headache due to the puncture of dura. Close the puncture by blood patch, which is called as epidural blood patch. Epidural. I'll write it over here. The definitive management is epidural blood patch. Okay, and which is the nerve that usually gets damaged in spinal? It is the sixth cranial nerve. Sixth cranial nerve. Again, guys, sixth cranial nerve is having a long course. If the patient is losing much CSF and all, then there will be sagging of brain over the sixth cranial nerve and the patient might have palsy. So usually I don't panic if I see this kind of reading after spinal anesthesia. This kind of reading, yani ke, if the BP falls like this, bradycardia happens, I don't. Why? Because I'm preparing the emergency drug tray. Okay. Usually the reaction of the ones who are not prepared, they will be having this reaction. Utha le re baba, patient ko nahi, but BP ko utha le after spinal. Okay. Now guys, what is this? We'll discuss something about spinal. Where are you giving spinal anesthesia? At what site are you giving spinal anesthesia? You are giving at the lumbar intervertebral space. कौन सी lumbar intervertebral space? Remember, in adults, the spinal cord is ending at the lower border of L1 and between the lower border of L1 and upper border of L2. Hence, in order to avoid the damage to spinal cord, what are we doing is, we are giving spinal in between L3, L4 or L4, L5 space, which is usually identified by a line which is called as Tuffier's line. Tuffier's line. Okay. Now, everyone look over here. There are two patients. Okay? Patient 1 who's posted for circumcision. Patient 2 who's posted for varicose vein surgery. Okay? In patient 1, the surgeon is telling, I will finish the surgery in 30 minutes. Both I'm giving spinal anesthesia. Okay? Surgeon is telling, I will finish the surgery in 30 minutes. In patient 2, he is telling that I will finish the surgery in 2 hours. Varicose veins. So in patient 1, how much ml of drug should I give? I'll give you options, guys. Okay? There are two options. In one patient we are giving 2 ml. In the other patient we are giving 4 ml. Now which patient requires 2 ml? Which patient requires 2 ml? Obviously, the circumcision patient requires 2 ml. Why? Because why am I giving a low dose? Why? Because the duration of spinal anesthesia is directly proportional to what? Directly proportional to the dose that you have given. That is very, very important. In varicose vein patient, I'll be giving 3 to 4 ml of drug. Okay. Next, guys, next discussing about epidural anesthesia. Epidural anesthesia. Now this needle over the screen, which is having light and dark band on it, this is called as what needle, guys? Epidural Tuhoy's epidural needle. This is used for what? Below umbilicus long duration surgeries. Guys, remember, spinal is given for below umbilicus surgeries which are done in 2 to 3 hours. Epidural is given for long duration below umbilicus surgery. Okay? Now, Epidural you can place. Spinal you are giving at lumbar intervertebral space. Epidural you can place at cervical, thoracic or lumbar, depending upon for what reason you are using. ठीक है. Epidural is used for labor analgesia. उसका ये मतलब नहीं है कि labor analgesia के लिए you put cervical epidural. No. Cervical epidural is used for neck radiculopathies or any lymph node dissection. Thoracic epidural is used for if at all patient is having rib fractures or if the patient underwent any CABG and he is having thoracotomy pain, you can place a thoracic epidural and give the drug so that the pain relieves. If the patient is posted for painless labor or below umbilicus surgeries, below umbilicus long duration surgeries, below umbilicus long duration surgeries, then you can place lumbar epidural. Lumbar epidural. That's regarding what, guys? Epidural anesthesia. Next is caudal. Caudal means what, guys? Caudal यानी कि it is given in children at the tail, यानी कि basically a child who is posted for some anorectal or perineal surgery, you give an epidural anesthesia at the level of sacral hiatus. Very, very important. Okay. What is the layer, guys? What is the layer? What is the last layer to be pierced in caudal anesthesia? That's very important. Sacrococcygeal ligament. Sacrococcygeal ligament. That is the last layer. Next, guys, next question. Which oxygen delivery device will deliver an FiO2 of 25 to 45%? Come on, guys. What's the answer for this? Nasal cannula, simple face mask, non-rebreathing mask, or Venturi mask. Come on. These are your options. Which will deliver? Guys, remember, for this, you have to remember, anesthesia mein you are having some numericals. How you should remember? You have to remember in case wise. Imagine a patient is in there in emergency. He just came with complaints of SOB. The first thing what you will do, you will tell the nurse that he's having shortness of breath. You check his pulse ox. His saturation is a bit low. So you tell the nurse, please place a nasal cannula. Nasal cannula, when the nurse places, how much of FiO2 will be delivered? Remember, how much of flow, yani how much oxygen, how much flow rate can be given through nasal cannula? The flow rate is 1 to 6 liters. Okay? And that 1 to 6 liters will fetch how much of FiO2? It will fetch 25 to 45%. 25 to 45%. Now the sister is telling you, sir, the doctor, the patient is not improving. Then what you need to do? Then you will tell the sister, please now shift to face mask. When you deliver the oxygen through face mask, it will deliver oxygen. How much? What will be the flow rate? Now remember, nasal cannula was not working. So face mask will deliver higher oxygen. So it will deliver 6 to 10 liters of the flow rate. Sorry, you can give 6 to 10 liters of the flow rate, which will deliver an FiO2 of 35 to 65%. Now again, the sister is telling, doctor, our patient is not improving. Then you will tell, please put an NRBM. What is NRBM? Non-rebreathing mask. She will ask, what should be the flow rate, sir? You ask her. Flow rate would be what? Should I give 1 to 6 or 6 to 10? No. NRBM means higher flow rate. What high flow rate? 10 to 15 liters will be the flow rate, which will deliver an FiO2 of more than 95%. Okay. If still not improving, then tell the sister, go for a fixed oxygen delivery device, which is called as Venturi mask, which works on Bernoulli's principle. Venturi mask will deliver 2 to 15 liters. The flow rate we can keep is 2 to 15 liters. And it will deliver an FiO2 of 24 to 60%. Okay? If still not improving, then you go for high flow nasal cannula, which in high flow nasal cannula, we can give 40 to 60 liters of oxygen that will deliver an FiO2 of 100%. So basically, remember guys, this is very important regarding the oxygen delivery device. Now, our question, which oxygen delivery device delivers an FiO2 of 25 to 45%. It is simple, guys. First, we go with simple nasal cannula. If that doesn't work, slowly from that face mask, NRBM, then Venturi mask, and last is high flow nasal cannula. Okay, guys? Okay, chalo. Next. 70-year-old male with coronary artery disease is on Thyronorm, clopidogrel. He is scheduled for elective TURP, which should be done preoperatively. Okay? Thyronorm यानी कि it's a euthyroid drug. Okay? Now, remember guys, what we need to do if the patient is on this. and this. One medication we need to continue, one we need to stop. So will you continue both? No. Will you stop both? No. Which needs to be continued? Thyronorm needs to be continued, and stop clopidogrel at least 8 days before surgery. But 8 days is not an option. Close to 8 days over here is what? 5 days. So remember guys, remember what principle the Venturi mask, it works on Bernoulli's principle. Yani कि basically oxygen flowing through a narrow jet-like passage is called as Bernoulli's principle. Okay. So guys, just look over here. What are the drugs which can be safely given before surgery? All active agents, yani कि all the drugs starting with the alphabet A can be continued, such as A stands for what? All antihypertensive medications can be safely given except of ACE inhibitors and ARBs. Next is what guys? Anti-lipidemic drugs should be continued. Anti-lipidemics, anti-cholesterol drugs can be continued. Next, anti-anginal medications can be continued. Next, anti-epileptic medications can be continued. Anti-epileptic. Next, anti-thyroid or euthyroid medications can be continued. Okay, what are the drugs which are stopped before surgery, guys? The drugs which are stopped before surgery are usually, remember guys, before taking the patient to the operation theater, will you allow the patient to go to the operation theater in his clothes? No. So basically, patient will be telling, should I wear my clothes or should I not wear? Yani ke, my clothes has to be stopped before surgery. That is the mnemonic. My clothes. M stands for what? Monoamine oxidase inhibitors are usually stopped 3 to 4 weeks before surgery. Next, clopidogrel has to be stopped 8 days before surgery. L stands for lithium, usually has to be stopped 24 to 48 hours prior surgery, right? O stands for oral hypoglycemic drugs are usually stopped on the day of surgery, Next, T stands for tricyclic antidepressants, usually stopped 3 weeks before surgery. H stands for heparin, and S stands for smoking has to be stopped before surgery. Okay guys, this is regarding what? This is regarding the drugs which are usually stopped. I told you Venturi mask usually works on Bernoulli's principle. We'll discuss that in coming questions. Okay. Right. Chalo. Next, some more points regarding fasting. Fasting, remember, if you usually before posting the patient for surgery, you tell the patient to be in a fasting state so that he is not at risk of developing aspiration. If he is on solid food, how many hours of fasting? 8 hours of fasting. Semi-solid, 6 hours. Clear fluid such as water, whether it is adult or child, it is 2 hours of fasting. Okay? If the child is brought to you and he's telling that he has consumed, the mother is telling he's on mother's milk, how many hours of fasting? 4 hours. If he's on formula feed, how many hours of fasting? 6 hours. Okay. Coming to the next question, guys. During airway assessment of a 50-year-old patient with obstructive sleep apnea, you perform the Mallampati test only to find the patient is having, when he's opening his mouth, you are seeing hard palate and soft palate. What is your interpretation and what's your plan? So basically, remember guys, Mallampati classification will tell you how easily you can intubate the patient. How it can tell? When you tell the patient to open mouth and you are able to see all the structures, that means you can easily put the laryngoscope, easily intubate. But if you're not able to see the structures, that means you're not able to, it's a difficult airway. Over here, what's the answer over here, guys? When the patient is opening mouth, hard and soft palate is visible. So it is 3 or 4, only hard palate visible, 4. Only hard palate and soft palate visible means Mallampati class 3, you have to prepare for advanced airway device. So guys, remember Mallampati classification uses, it gives you the prediction of how easy the patient's airway is. There are 4 classes, 1, 2, 3 and 4. 1 means what, guys? You are seeing all the structures. All the structures means what? All structures means you are seeing tonsillar pillars. The mnemonic is for MP1, it is push, P-U-S-H. P stands for tonsillar pillars, U stands for whole of uvula with the tip you are able to see, S soft palate, and H is hard palate. That is Mallampati class 1. Class 2 means what? USH. U means what? You are able to see the uvula. You are also able to see tonsillar pillars which are partially visible. S stands for soft palate, you are able to see, and H stands for hard palate, you are able to see. That is Class 2. Class 2 means you are able to see uvula but tip is not seen. Class 3 means what? Only you are able to see the soft palate as well as the hard palate. Okay. But you might also be able to see the base of uvula. No other part of uvula, only base is visible. Okay, that is class 3. Class 4 means only hard palate visible. Nothing else is visible. Class 0 is also there. Class 0 means what? When a patient opens his mouth, he's having such a good airway that you are able to see all push. Push means what? Pillars, uvula, soft palate, hard palate, plus you are also able to see the epiglottis, tip of epiglottis visible. That is class 0. Tip of epiglottis visible. That is class 0. All class 1 structures plus tip of epiglottis, class 0. Okay. Now guys, tell me, how's the airway of this patient? This patient or this person? Remember this guy from Mirzapur. खास जगह का कैंसर हो सकता है बोलते हैं ना इसको. हॉरिबल एयरवे. ठीक है ठीक है ठीक है. डिफिकल्ट एयरवे. ठीक है. डिफिकल्ट एयरवे. मुन्ना भैया बोलते हैं ना इसको. अमर हम है तुम नहीं. Anyways, guys, remember, if you are predicting a difficult airway, you prepare yourself with a difficult airway set. This is a difficult airway set where you are having different laryngoscope, numbers of laryngoscope, different airway devices, oral airway devices, different sizes of LMA available with ET tube and all. Okay. Vimal special air. Okay. 65-year-old man with uncontrolled diabetes is undergoing PAC before elective cholecystectomy. His ASA physical status is. ASA is basically a certification that you can undergo anesthesia. Okay. So, abhi iska, what is this? ASA. Uncontrolled diabetes. Come on guys. ASA 1, 2, 3 and 4. Again, you should answer this in seconds. What's the answer? ASA 3. Now, why am I telling you? Why should you should answer in seconds? Remember guys, ASA is a certification. In simple language, I will tell you. Just look over here. ASA 1 means what? I am healthy, no problem. ASA 2 means what? I am having mild disease. That is ASA 2. ASA 3 means what? I am having moderate to severe disease. ASA 3. ASA 4 means what? I am at risk of dying due to the disease. Yani ki I am having a disease that poses threat to my life. That is ASA 4. ASA 5 means what? I might die. Why? Because I am in a moribund state. That is 5. ASA 6 means what? I am dead. Dead patient is ASA 6. So basically that is a simple term, but remember ASA 1 is what? Free from systemic illness. 2 means what? Patient having systemic illness which is mild and under control. Okay? Example, mild and under control. Now example is basically patient is a social smoker or having diabetes under control. Class 3 means what? Patient is having systemic illness which is not under control. Yani ke patient is having moderate to severe systemic illness, uncontrolled diabetes, moderate ejection fraction decrease, BMI more than 30. ASA class 4 means what guys? ASA class 4 means patient having life-threatening disease. Having life-threatening disease. ASA class 5 means moribund patient. Okay? Without surgery, survival is less. Usually ruptured abdominal aortic aneurysm. ASA class 6 means brain dead patient. That is ASA classification. Coming to the next question, guys. Select the correct pair of local anesthetic, which is regarded as the shortest acting and which is regarded as the most cardiotoxic. Come on, guys. Shortest as well as the most cardiotoxic local anesthetic. What's the answer? Right. So for that, what we need to remember is, just a second. Right. So guys, for that, what we need to remember is, also most of you have given answer as A, some of you have given answer as D. Now we will solve this, guys. Remember, longest to shortest acting local anesthetic, this mnemonic was what? Delhi to Bombay loves PC. PC could be Priyanka Chopra or Priyanka Chopra anyways, okay? So D stands for what? Longest to shortest. D stands for dibucane is regarded as the longest acting. Second after dibucane is what, guys? Tetracane. Now after tetracane, what is the next thing? Bupivacaine. Bupivacaine. Next after bupivacaine, next lignocaine. More short than lignocaine is procaine. Procaine, which is regarded as the safest local anesthetic in malignant hyperthermia. Shortest is chlorprocaine. Chlorprocaine, or it is also called as chloroprocaine. Okay? So remember that this is the shortest. Now he was asking what? Which is the most cardiotoxic? The most cardiotoxic, always the award goes to what? It is bupivacaine. It is bupivacaine. Most commonly used local anesthetic worldwide, it is what, guys? Most commonly used worldwide is lignocaine. Okay. So the answer over here is shortest is chlorprocaine and most cardiotoxic is bupivacaine. Now, as we are discussing lignocaine, guys, remember lignocaine is the most commonly used local anesthetic worldwide. There have been questions on lignocaine, and all the questions of lignocaine can be solved by looking at the spelling of lignocaine. The three first letters of lignocaine will tell you the all three MCQs, all 3 to 4 MCQs it can cover. LIG. L stands for what, guys? L of lignocaine means what? It is the most commonly used local anesthetic worldwide. L stands for most commonly used local anesthetic worldwide. I stands for it is the most commonly used local anesthetic in IVRA, intravenous regional anesthesia. G stands for what? It is the local anesthetic that can cause malignant hyperthermia. G stands for, G say malignant hyperthermia means what? G stands for Garmi. Garmi means high temperature. So it is a local anesthetic that can cause malignant hyperthermia. G stands for Garmi. Okay. So that is regarding lignocaine. When you are giving lignocaine, what should be the dose, guys? The dose of plain lignocaine is 4.5 mg per kg body weight if you are giving plain lignocaine. But if you are mixing adrenaline and giving with lignocaine, the dose becomes how much, guys? 7 mg per kg body weight. Okay, that is the dose of lignocaine. But don't exceed the dose and give. If you exceed the dose, patient will land up into lignocaine toxicity. And lignocaine usually produces what toxicity? It produces central nervous system toxicity. Okay, next, guys. 25-year-old patient posted for cesarean section. Immediately after spinal anesthesia, patient develops arrhythmias. A diagnosis of accidental intravascular injection was made. Which drug could have caused this? Come on, guys. Answer is very simple. He is asking patient developing arrhythmias after accidental IV injection of which drug? Again, you need to remember the most cardiotoxic. He's basically asking the most cardiotoxic local anesthetic. It is always bupivacaine. Bupivacaine. Remember, lignocaine produces toxicity of what system? Lignocaine. If you give lignocaine, it will produce toxicity of CNS. What is the first sign of lignocaine toxicity? Patient complains of perioral numbness. Perioral numbness. That is regarding lignocaine. But bupivacaine will cause cardiotoxicity. It is CVS toxicity. Okay? So if at all patient develops arrhythmias due to bupivacaine, you can give amiodarone to the patient. But the treatment of choice is what, guys, for any local anesthetic toxicity? It is intralipid solution, 20%. Okay? Yes. The chances of local anesthetic toxicity is high when given through which route? Come on, guys. If you are giving local anesthetic to the patient, the chances might be high if you are giving through which route? Come on, guys. If I give local anesthetic intercostal, chances of local anesthetic toxicity are there. Brachial plexus, chances are there. But much higher are there if you are giving IV followed by tracheal. Okay? So remember, chances of local anesthetic toxicity depends upon the absorption. IV, tracheal followed by intercostal and brachial. Okay? Next. When you are giving local anesthetic to the patient, what is the primary action? How is this acting, guys? Remember, local anesthetic acts by acting on the sodium channel. So when you give local anesthetic, it enters the nerve in one form. What form? Non-ionized. and that non-ionized form goes towards the nerve terminal, knocks the door of the nerve terminal, and the nerve terminal takes the non-ionized, and then it becomes ionized, and it searches for what channels? Sodium channels. Once sodium channel is searched, what you need to do? It will block the sodium channel, and once sodium channel is blocked, depolarization is gone. Okay, so that is the local anesthetics. Okay, now best way to confirm endotracheal intubation is by, come on guys, best way to confirm, yani ki you have put the endotracheal tube, how will you confirm it? By auscultation or visible chest rise or capnography or pulse oximetry? Come on. Is by, very good, it is by capnography. Auscultation, visible chest rise, pulse oximetry, these are the screening things. But the best is what? Capnography. Capnography is you connect the endotracheal tube to a graph which is called as, which will basically collect the information on what? On exhaled carbon dioxide. Okay, we'll discuss about capnograph as we are proceeding. Okay, resistance to airflow in an endotracheal tube is primarily affected by. Now guys, you have, this is a very important question. Okay, resistance to airflow of endotracheal tube is primarily affected by length, radius, compliance, or the density. Come on, what's the answer? The resistance to the airflow usually depends. If you are taking a high diameter tube, the resistance will be low. Low diameter tube, resistance will be high. So it basically depends on the radius or the internal diameter of the endotracheal tube. Okay? Regarding endotracheal tube, guys, you need to remember endotracheal tubes, previously we used to use red rubber. Now we are using PVC tubes. PVC also, there are two tubes, cuffed and uncuffed. So remember, the best way to secure the airway is by endotracheal intubation. Endotracheal intubation. Okay? Previously we were using what? Red rubber tubes. But are we using this red rubber tubes now? No. Why? Because red rubber tubes what was it causing? Red rubber tubes were low volume, high pressure. Due to this low volume and high pressure, the patient was developing tracheal mucosal injury. Tracheal mucosal injury. So nowadays we are using what tubes? PVC tubes. This PVC tubes are commonly used tubes in the OT as well as ICU, and in the PVC, which are the common one, guys? The cuffed endotracheal tube is common. The cuffed endotracheal tube is common. Okay. Right. Next, what does the number on endotracheal tube say? Remember guys, there is one number written on endotracheal tube like 7 or 8. What does it mean, guys? That is the size. What does the size of endotracheal tube mean? Size means, is it the length of the tube? No. What is it? It is the internal diameter. It is the internal diameter of the tube. Okay. Now, solve this question, guys. After intubation, we auscultate and hear breath sounds only in the right chest. What does it mean? You have intubated the patient and now you auscultate. Normally, if your tube was in the mid trachea, you will see breath sounds both in the right as well as left lung. Okay, imagine this is the right and this is the left. So, but what is he telling? He is telling only breath sounds in the right. What does it mean? It means your tube is too deep inside. You have intubated and put the tube too deep inside. It has gone into the right bronchus. It means you have done right endobronchial intubation. Right endobronchial intubation. Okay. Next. Patient was intubated. Again, this was also asked, guys. Patient was intubated and he was kept on mechanical ventilator for weeks. Now he develops inspiratory stridor. What is the cause of it? Come on, guys. Remember, just look over here. Okay? Patient, this is the trachea of the patient. He was intubated and kept on mechanical ventilator. We have used the cuff tube. When you intubate the patient and keep him for a long time, what will happen is this portion of the trachea gets narrowed. That is which portion, guys? This is called as subglottic. Okay? So patient had developed this. This is called as subglottic stenosis. Subglottic stenosis will produce this. Okay? Remember, subglottic stenosis, you won't see inspiratory stridor as the Common thing. In subglottic stenosis, you will see biphasic stridor, but initially it starts as inspiratory. On inspiration, the patient will have this. Then slowly it will become biphasic stridor. Okay. Next, if a patient is having maxillofacial trauma cases there, his jaw is totally dislocated and all, and like a road traffic accident he had, how will you secure the airway? How will you secure the airway? Initially, how will you secure the airway? Initially, if the patient is having maxillofacial trauma, blood in the oral cavity, the best way still is what? Initially, orotracheal intubation. But now you will be asking, sir, how orotracheal intubation? There is blood in the oral cavity. There is a chance of aspiration. Yes, there is a chance of aspiration, but the best way to secure is orotracheal. How? By video laryngoscope. You put a video laryngoscope, you do suction, constant suction you have to do, and then you have to put the tube. Okay, with the help of video laryngoscope. But if at all that fails, still you are not able to see the vocal cords, the definitive management is what? Like, don't do anything to the oral cavity, cut open the trachea. That is called as tracheostomy. That is tracheostomy. Okay, next. What is the pin index of nitrous? Guys, remember, pin index system is a system that prevents wrong attachment of the cylinders. Okay, so wrong attachment of the cylinders to the machine. There is an integrated system. What is a pin index system, guys? For nitrous, the answer is, obviously you have given the right answer. Just we'll go for the pin index system. Pin index system, the pins are present on the machine, holes are present on the cylinder, and different gases are given different pin index so that you can just so that there is no wrong attachment. Air is given a pin index system of 1, 5. Oxygen is given 2, 5. Nitrous is given 3, 5. Entonox is given. Entonox is nothing but 50% oxygen, 50% nitrous, guys. Entonox is 50% oxygen, 50% nitrous. It is given as a pin index system of 7. And carbon dioxide is 1, 6 and 2, 6. So remember, guys, 1, 5 means what? If it is an air cylinder, it will fill into the first and fifth port. If it is an oxygen, it will fill in the second and fifth port. But you have to remember the spin index system. How will you remember? Air, oxygen, nitrous, these are important and very easy to remember. The common thing over here is what? The second pin index. For air, oxygen and nitrous, the second pin is always 5. So we just have to remember the first. How to remember the first pin? Air starts with alphabet A, which is the first alphabet. So it will be 1, 5. Oxygen, when you are writing oxygen, always write O2. O2 means what? 2. So 2, second is always 5. Nitrous means what? N2O, yani 2 molecules of nitrogen, 1 molecule of oxygen. How many molecules? 3. So it will be 3, 5. Okay, it will be 3, 5. Entonox is pretty simple, guys. 7 alphabets are there in Entonox. So pin index system for Entonox is 7. Is it clear? Chalo. Next. Which of the following inhalational agent requires a special vaporizer? When we are talking about vaporizer, guys, remember vaporizer is an instrument that usually holds liquid inhalational agent in it. Okay? Only remember, normally vaporizer is normally all inhalational agents are stored in one category of vaporizer, but one inhalational agent requires a special vaporizer as it is having a low boiling point. What is that, guys? Desflurane, which is very costly vaporizer. Okay, so desflurane requires a costly vaporizer. Normal vaporizers are made up of what material? These are made up of copper material, and desflurane requires a special vaporizer. As I told you, it's having a low boiling point. There is some color coding given for the vaporizer also. Guys, remember what's the color coding for vaporizer? For halothane, hell. Halo yani ki halothane. Hellfire is red in color. So halothane vaporizer color is red. Isoflurane, the vaporizer color is what, guys? Purple. Okay. Sevoflurane, always remember Sevo yani ki sevaiya. Sevaiya is liked by children. Why? Because it is sweet. I'm telling you why to remember. Why? Because Sevo, sevaiya liked by children. Why? Because it is sweet. And what is the color of sevaiya? Yellow. So remember yellow color. Now with this Sevo, sevaiya yellow, you can remember Sevo is stored in yellow color vaporizer having sweet odor and commonly used in children for induction purpose. Okay. D stands for what, guys? D stands for desflurane. Yani ki desi vaporizer, desi color is what? Blue. Chalo. Next. Concentration of adrenaline used in cardiac arrest. Come on, guys. Adrenaline concentration in cardiac arrest. What does it mean? 1 is to 1,000, 1 is to 10,000, 1 is to 20,000, 1 is to 2 lakh in cardiac arrest. Remember, guys, adrenaline concentration in cardiac arrest is how much, guys? 1 is to 10,000. That means 1 gram in 10,000 ml of water or 1 milligram in 10 milliliters of water. Okay. So now remember the concentrations of adrenaline you have to remember. In cardiac arrest, it is 1 is to 10,000. In local anesthetic, it is 1 is to 2 lakh. Whereas in anaphylaxis, it is 1 is to 1,000. Okay. And how will you give adrenaline in cardiac arrest patient? The best route is IV. If IV is not possible, directly in the bone, that is intraosseous. If that is also not possible, you go for, you have already intubated na, so you can put adrenaline through the endotracheal tube, that is endotracheal administration. That's regarding what, guys? That's regarding the concentration of adrenaline in cardiac arrest. Now, guys, here, right, next, which of the following is an amino ester local anesthetic? Come on, guys. Amino ester local anesthetic. Amino ester local anesthetics are categorized into two categories: amino ester, amino amide. Amino ester यानी कि 1 eye, amino amide यानी कि 2 eyes. Amino esters, crocaine, procaine, chlorprocaine, tetracaine, benzocaine, all are having 1 eyes. Proparacane, all are having 1 eye. So over here, what's the answer over here? Procaine. ठीक है? All amino esters are having 1 eye. Amino ester में ही एक eye है ना? Amino ester. So all amino esters will have 1 eye. Cocaine, procaine. Now, the question there, usually remember, guys, almost all local anesthetic will cause vasodilatation, but only cocaine is the local anesthetic which causes potent vasoconstriction. It will constrict the blood vessels. Due to this reason, we have seen many cases who are who are IV cocaine abusers or cocaine abusers. They are usually either landing up into hypertension or into stroke. Why? Because it will cause potent vasoconstriction that will increase the BP. Okay. So procaine, benzocaine, tetracaine, chlorprocaine, and proparacane. Remember, proparacane is a topical ocular local anesthetic. Next category of local anesthetic is amino amide. Amino amide you can easily identify, guys. Amino amide by looking at the spelling. How many eyes are there in amino amide? 2 eyes. So all the drugs in amino amide category will have 2 eyes: lignocaine, mepivacaine, bupivacaine, prilocaine, dibucaine, which is the most commonly used local anesthetic worldwide. Worldwide, it is always what, guys? Lignocaine, which is most commonly used in spinal anesthesia. It is always bupivacaine. Most cardiotoxic is also bupivacaine, right? Now, guys, remember, if you are giving a local anesthetic, and after giving that local anesthetic, imagine a patient is posted for some surgery that requires 3 to 4 hours of local anesthetic effect. Patient is posted for some surgery under spinal anesthesia which requires 3 to 4 hours of effect, and you have to give spinal anesthesia only, and you are giving bupivacaine. Your bupivacaine acts for 3 hours. Can you add something to bupivacaine that will increase the duration? Guys, don't tell me now that increase the dose. We have already used the maximum dose. With maximum dose, can you add something to bupivacaine that will increase the duration? Yes. What is that drug called as, guys? Those are called as additive drugs. Additive means you can add adrenaline, you can add soda bicarb, you can add opioids. Remember, guys, one opioid is usually avoided. Usually, most commonly, you are using opioids. One opioid is usually avoided. What is the opioid that is avoided in spinal? I'm not telling it is avoided everywhere. In spinal, it is avoided. What is that opioid? It is remifentanil. Why? Because it contains neurotoxic preservative. Neurotoxic preservative. So anyways, opioid you are adding, all opioids, fentanyl, alfentanil, sufentanil, you are adding. It will increase the duration, but it comes with a side effect. What side effect? When you give opioid, the most common side effect that you see is patient might have pruritus or itching. Okay, apart from that, nausea, vomiting, respiratory depression could be seen, but these could be the side effects. Okay, remifentanil is used in daycare anesthesia, daycare surgery, that is for general anesthesia, but in spinal anesthesia, remifentanil is avoided with bupivacaine. Okay, that's regarding what, guys? That's regarding the opioids. Now, guys, imagine you have given some local anesthetic to the patient, and after receiving local anesthetic, patient is telling, Doctor Saab, खुजली हो रही है, ठीक है, खुजली यानी कि किस किस्म की खुजली नहीं, जस्ट खुजली हो रही है, पेशेंट इज हैविंग itching. What could be the local anesthetic which can cause itching? I have not given any opioid, just I have given local anesthetic and patient is having itching. Which local anesthetic will cause itching, guys? Come on, this could be a question. Local anesthetic that can cause itching or any allergic reaction is what? It is always amino ester. And which local anesthetic will cause allergic reaction? The local anesthetics which are metabolized to PABA. My question was, what anesthetic, local anesthetic would have I have been given? Remember, the local anesthetics which are metabolized to a compound PABA. If you remember the spelling PABA, you can remember the answer. Okay, P stands for, remember in amino ester, which is the local anesthetic which is starting with alphabet P, it is basically procaine that can cause allergic reaction. B यानी के benzocaine. So benzocaine, these can cause allergic reaction, right? Next, which of the following drug is contraindicated in IVRA? Come on, guys, it's very simple. Third time it is coming in different, same drug coming in different form for the third time. Which drug is contraindicated in IVRA? What is IVRA? First we need to understand. IVRA means intravenous regional anesthesia. Meaning what, guys? Patient is posted for some surgery. Okay? Patient is posted for some surgery, right? He from some radial fracture surgery, patient is posted. You want to anesthetize only this area. You are not giving general, only this area while whole body is normal. Is it possible? Yes. You place an IV cannula. You give an IV anesthetic agent. Okay, lignocaine. This lignocaine will block this area, but it won't go up. How is it possible? You will apply a tourniquet over here so that the lignocaine that you give, it will just work on this area. That is called as intravenous regional anesthesia, also called as Bayer's block. All can be given except this drug. What is that drug? Bupivacaine. Bupivacaine, most cardiotoxic, never given IV. Most cardiotoxic, never given IV. Okay. So IVRA, I have told you, it is also called as Bayer's block. In IVRA, the important thing could be what? When you are applying a pressure in the upper limb, what is the, sorry, when you are applying a tourniquet of the upper limb, what is the pressure of tourniquet? What is the pressure in upper limb, guys? When you are applying a tourniquet. Remember, for upper limb, the pressure should be 50 plus systolic BP. 50 plus systolic BP. That means what? Systolic BP is usually, I'm giving an example, 120. 120 plus 50, yani ke you apply a tourniquet at a pressure of 170. In lower limb muscle mass is much, so it requires much pressure to block the supply. So in lower limb, the pressure is 100 plus systolic. 100 plus systolic BP. Okay. There is one more thing called as EMLA, guys. Heard about EMLA? EMLA is nothing but eutectic mixture of local anesthetic, in which you are having 2.5% of prilocaine and 2.5% of lignocaine in it. Okay? But remember, why you are applying this? Imagine a child is there who is in the casualty, who is not allowing you to put an IV cannula. Why? Because he's afraid of the pin prick and all. So you can apply a local anesthetic cream, that is EMLA cream, but it is usually avoided in neonates. Why? Why? Because if you give EMLA in neonates, then this prilocaine can cause methemoglobinemia. Methemoglobinemia. Due to this reason, it is contraindicated in neonates. Okay. Next, guys. Among the oxygen delivery device, which will work on Bernoulli's principle? Come on, guys, which is working on Bernoulli's principle? Bernoulli's principle is what? High flow of oxygen passing through a narrow jet-like passage is called as Bernoulli's principle. We have already discussed that. Which is working, guys? It is the Venturi mask. Very good, Venturi mask. So this is the oxygen delivery devices which we have already discussed. Okay. Now next, coming to Ambu. Ambu, what is the full form of Ambu? Artificial manual breathing unit, which will deliver 100% of oxygen. And on the Ambu, you are having two valves. One is called as a Rubin's valve, which is a unidirectional valve that prevents rebreathing, and one is called as a pressure relieving valve, which is usually seen in pediatric Ambus, Okay, what is the pressure that it relieves? At what pressure it gets relieved, guys? It is 35 to 40 centimeters. 35 to 40 centimeters of water. Okay. Next, pediatric ambu bag is of different volume, adult ambu bag is of different volume. Match the following substances with their appropriate antidotes. Benzodiazepines, if at all you are giving benzodiazepines, what is the antidote? If at all you are giving alcohol, what is the antidote? So remember guys, benzodiazepines, when you are giving, the antidote of benzodiazepine would be flumazenil. If the patient is for alcohol, what is the antidote guys? It is fomepizole. For opioid, it is what? It is naloxone. And if the patient is taking arsenic and all, the antidote is what? It is a chelating agent, BAL. Okay. So that is the antidote. And the correct answer is what? Over here, it is A. Benzodiazepines, alcohol, opioid and arsenic. Okay. Which fluid is regarded as the fluid of choice for elective surgery? For elective surgery, guys, what is the fluid that which we commonly use? For elective surgery, it is Ringer's lactate. Ringer's lactate. Normally, we are using crystalloids only. In crystalloids, the fluid of choice is always Ringer's lactate for elective surgery. Colloids are usually avoided nowadays. Why? Because they can produce allergic reactions. Okay. Next, identify the device which is shown in the image. Come on guys, this device is very simple and very easy to identify also. A person who's there in a person was brought to the casualty with the I'm just giving an example, with the complaint of fits or epilepsy. Okay, and now patient might injure his tongue. So what we can do is we can put an airway device that will prevent the tongue bite, as well as that will prevent the collapse of the airway and keeps the airway patent. What is that called as, guys? Which is the airway device? It is a oropharyngeal airway, which is also called as Goodell's airway, and it is very simple to use it. First, before using, take a Goodell's airway, keep between the tragus of ear and angle of mouth. If it is fitting, then you have to use that size of airway. Okay, this is the oropharyngeal airway. This is the oropharyngeal airway. Okay. Next is one more airway is there, nasopharyngeal. Imagine a patient is there who's coming with epilepsy or fits, and he's having clenched, his mouth is clenched and his oxygen saturation is falling. You need to keep the airway patent. You cannot keep the airway device intraorally, okay, until the fit is gone. So till that time, if you want to keep the airway patent, you can place a oxygen, you can place a nasopharyngeal airway, and you can mask ventilate the patient. Okay, nasopharyngeal airway. But remember, there are some contraindications to it. If at all the patient is having skull base fracture, don't place it. It can easily penetrate and it can damage the brain. Or if the patient is having bleeding disorder, you don't go for nasopharyngeal airway. So two airway devices, NPA is there and OPA is there. Okay. Gag reflex may contraindicated as Goodell's airway. If the patient is having gag reflex, instead of Goodell's airway, you go for NPA if the patient is having gag reflex. Okay. Next, which nerve is being stimulated for the mentioned test? Come on guys, A, B, C, D. Which nerve is being stimulated for the test? Very good. Ulnar nerve. So what is the test which is being done over here called as? It is called as train of 4 test. Guys, what is train of 4? I want my students to remember train of 4 in a very easy manner. Okay. So just look over here, guys. Train of 4 means I am just applying some electrodes over here. I'll be giving shock. I'll be stimulating this ulnar nerve, which will basically produce a twitch. 4 times I will stimulate, 4 times I will see twitch. Now just look over here. Okay, imagine this monitor is being applied over here. I have not received any muscle relaxant. So what will you see if I give 4 shocks? You will see 1, 2, 3, 4. 4 twitches you will see. 4 shock, 4 twitches. Yani ke first twitch is called T1, second twitch T2, third twitch T3 and fourth twitch T4. And what is the height of 4 twitches? In a normal patient, what is the height of all 4 twitches? First twitch also same, second also same, third also same, fourth also same. So if someone asks you, in a normal person, what is the train of 4 ratio? What is meant by train of 4 ratio, guys? Train of 4 ratio is nothing but T4 by T1. All 4 twitches heights are same. The ratio will be 1 in normal person. Now, Now we are discussing. If someone gave me muscle relaxant and then 4 twitches are given to me, just look over here, what will happen? Okay? And which muscle relaxant? Depolarizing muscle relaxant. Just look over here. What will happen? After 2 minutes of depolarizing muscle relaxant, you will see this. First twitch, second twitch, third twitch, fourth twitch. Yani कि basically before receiving muscle relaxant, how was the twitches coming? First, second, third, fourth. This was before. And after using depolarizing muscle relaxant, first, second, third, fourth. Yani कि all 4 twitches are coming, but they are coming with a decreased intensity. But all are same. All 4 twitches height is same only. So if you are using a depolarizing muscle relaxant, just look over here, guys. What you will see? You will see a decreased response in twitches, but of equal height or equal intensity. Okay? Equal intensity. So how will be the train-off-4 ratio in case of depolarizing muscle relaxant? In case of depolarizing, T4 by T1 ratio will be same, 1 only. But if I received a non-depolarizing muscle relaxant, everyone look over here. If I receive a non-depolarizing muscle relaxant, what will happen? Okay? After 2 minutes, you will see. And now you guys tell me. T1, T2, T3, T4. Now, what had happened, guys? Just now I showed you. Once again, I'll show you. If I use non-depolarizing muscle relaxant, T1, T2, T3, T4. All 4 twitches are of equal height. They are decreased, but are they equally decreased or one twitch is more decreased than the other one? We'll graphically write it, guys. Just look over here. First twitch like this. Second like this. Third like this. And fourth very low height. So how will be the T4 by T1 ratio? It will be how much, guys? It will be less than 0.4. You will see a fading effect. Fading effect is seen under non-depolarizing muscle relaxant. Okay? Under NDMR, you will see a fading and the ratio will be less than 0.4. And which is the first twitch to disappear? The last twitch. The T4 is the first twitch to disappear. Which is the first twitch to reappear or reoccur? It is the first twitch. Okay? First twitch. So, this is regarding train-off-4. What is the most common nerve, guys? It is the ulnar nerve. And what is the muscle, guys? Adductor pollicis. Adductor pollicis. Take a train-off-4 ratio, you know, in depolarizing it is 1. In non-depolarizing less than 0.4. And for reversal, what is the train-off-4 ratio required, guys? For reversal, yani now surgery is done. Now you need to reverse the patient. Train-off-4 ratio should be more than 0.9. Is this thing clear, mere bhai? Yes or no? Okay? I think it should be clear till now. 45-year-old patient is underwent laparoscopic surgery under GA. Post-surgery patient came to the surgeon that he remembers all the conversation that happened in the OT while he was under anesthesia. He was able to feel, but he was not able to move. Which monitoring could have prevented? Yani कि basically patient was aware during anesthesia. Patient was aware during anesthesia. Why it could happen, guys? Remember, what is the thing that usually maintains the patient in unconscious state? Inhalational agent. If your inhalational agent is not working properly, patient might be aware. How will you come to know? Patient is relaxed, muscles are relaxed. You have given paralysis, you have paralysis muscle. How will you come to know he's aware or not? Okay, by a monitoring which is called as BIS monitoring, bispectral index. Okay, you keep EEG electrodes and then you calculate the sum of EEGs. Okay, with that you will come to know awareness during anesthesia. Okay, the values might come as like 100 or less than 40. 100 means the patient is awake, less than 40 means patient is in a deep hypnotic state. Now, if we are discussing about monitoring, we have to discuss something more about monitoring. In anesthesia, during anesthesia, what are the things we monitor for? We monitor the patient's oxygenation, we monitor the patient's ventilation, we monitor the patient's temperature, we monitor the patient's BP and all. Okay, so oxygenation of the patient is monitored by what? Oxygenation is monitored by simple thing, guys, which is called as pulse oximetry, which usually works on what? Which usually works on Beer-Lambert's law. Ventilation is monitored by, once you intubate, you connect the machine to the capnograph. ठीक है? Ventilation is monitored by capnography. Circulation is monitored by what? By BP, ECG, and a thing called as TEE, which is transesophageal echocardiography. In BP, there are two types. One is invasive blood pressure monitoring that is required in sophisticated or a high-risk surgery. In that invasive blood pressure monitoring, what is the artery which is commonly used, guys? Radial artery. And radial artery patency can be checked by Allen's test. The patency can be checked by Allen's test. ठीक है? Next, NIBP यानी कि नॉन इन्वेसिव इज देयर. नेक्स्ट ECG. In ECG, 2 leads are important. 12 leads की जरूरत नहीं है. Only 2 leads. What 2 leads? Lead 2 detects what? Lead 2 detects arrhythmias, whereas lead 5 detects ischemias. Lead 5 detect any ischemias. TEE is what, guys? Transesophageal echocardiography. यानी कि you are putting the echo probe through on the endoscopy and you keep it in the esophagus and you take the heart pictures. Again, TEE is used for what? To detect venous air embolism. Transesophageal echocardiography is useful. Like last is temperature monitoring. Temperature monitoring, you can go for peripheral as well as core temperature monitoring. Core temperature, remember, most commonly you keep the temperature probe in the esophagus. That is most common site for monitoring the core temperature. Okay? But the most accurate is what? It is the pulmonary artery. Pulmonary artery. It is the most accurate one. Next, a 55-year-old patient undergoing left thoracotomy receives one lung ventilation. Which tube is most appropriate? Come on, guys. For one lung ventilation, what is the tube normally used? Answer is what? Normal ED tube, if you use, it will ventilate both the lungs. Flexometallic, ventilate both the lungs. Ray tube, yani ke ring adire Elvin, that is nothing but nasotracheal. Remember, all other tubes, apart from double lumen, all other tubes will go till this level only. Okay? We want a long tube which goes into the right bronchus and you will just ventilate the one lung. Yani ki one lung ventilation means only one lung ventilation is required. Other lung surgery is there. Okay? So what is the tube that is used, guys? It is the double lumen endotracheal tube. That is very, very important. Okay? As you place this double lumen tube, it will be placed in the right bronchus and you can ventilate the right lung. Okay? You can also go for a left lung depending upon what surgeon is telling. Now, once you place a double lumen tube, how will you know the placement, exact placement and all? Remember, for normal endotracheal tube, capnography was the best one. But the placement of double lumen tube is confirmed by what? By fiber optic bronchoscopy. Fiber optic bronchoscope. Fiber optic. After putting a double lumen tube, put a fiber optic bronchoscope and check with the camera where is the double lumen tube. Okay. Next. An RTA patient arrives in emergency department with hypotension and active bleeding. The anesthesiologist plans for rapid volume resuscitation before shifting the patient to OR. Which of the following IV cannula is most appropriate for this situation? Come on, guys. Patient RTA का है, उसको आपको rapidly you have to infuse blood or rapidly you have to infuse the volume. Which IV cannula is used? Very good. 14 gauge, which is a large bore IV cannula. For IV cannulas, there is a mnemonic, guys. Oh, great God, please bless your people. Okay? Oh, great God. O stands for orange color IV cannula. G stands for gray. So remember, O, orange color, which is the largest bore, 14 gauge. Gray color, 16 gauge. Green color, 18 gauge. Please, यानी के pink color, 20 gauge. Bless. Blue color, 22. Yellow is 24. And people, यानी कि purple is 26. In pediatric cases, we are using yellow and purple. Purple, we are not using at all. But for pediatric, we use this. Okay? Normally, for all kind of surgeries, we are using, for normal surgeries, we are using this green and pink color cannula. Now, there have been questions on what is the flow rate of IV cannula. The flow rate of IV cannula, if you want to remember, come from the down till bottom. यानी कि per ml how much of fluid is given, per minute how much of fluid is given. So per minute, if you are putting a purple cannula, it is 10 ml per minute. If it is yellow cannula, double of it, 20 ml per minute. If it is blue cannula, 30 ml per minute. If it is pink, 50 ml. and green 100 ml, gray 200 ml, and 14 gauze or orange, it is 270 ml per minute of fluid is given. Okay, yes, we can use blue in pediatric cases. We can use blue in pediatric cases as well as adults, depending upon how the vein diameter is. If vein is good, you can go for blue. Otherwise, if vein is very small in pediatric cases, go for yellow. Purple we are not using. Okay. Next, 45-year-old male with acute intestinal obstruction, vomiting, is posted for emergency laparotomy. He is alert, dehydrated. He has not fasted. During induction, which of the following is the most appropriate airway plan? Remember guys, normally we tell the patient to be in a fasting state, but in emergency you cannot tell the patient to be in a fasting state. You have to take, intestinal obstruction is an emergency. In emergency, if you want to take the patient who's full stomach, if you want to give anesthesia with general anesthesia, then what is that called as? You have to go for RSI. Giving general anesthesia to a patient whose full stomach is called as RSI, rapid sequence induction. So what you should do guys in rapid sequence induction, you pre-oxygenate the patient, induce with propofol, apply cricoid pressure, then give scoline, and then intubate. That is very, very important. Okay, remember guys, cricoid pressure is also called as Selleck's maneuver. So first of all, we are discussing RSI. RSI is rapid sequence induction. That is basically giving GA to high-risk patient. Who are high-risk patient? Obese patient, pregnant ladies, GERD, hiatus hernia, or any emergency. These patients are at risk of aspiration. If you want to give them, then you have to give rapid sequence induction. If you want to give GA to them. Okay? So in rapid sequence induction, we pre-oxygenate with normal mask. Then immediately after IV induction, we give IV induction, and immediately after an IV induction, what is being applied guys? Pressure is being applied on cricoid cartilage. What is that pressure called as? That pressure is called as Selleck's maneuver. That is called as what guys? Selleck's maneuver. Okay? Now the question is, when will you remove Selleck's maneuver? When will you remove it guys? Once you have intubated, inflated the cuff, and then Selleck's maneuver is removed. Answer is, when are you removing the Selleck's maneuver? When are you removing this pressure? Once intubated and inflated the cuff. Next guys, patient was planned for surgery under general anesthesia. In the induction phase, rocuronium was given. Anesthetist did not succeed in intubating. Hence, which should be the best reversal agent used? Neostigmine, physostigmine, Sugammadex, atropine. Guys, remember, atropine is never an option. Atropine is not a reversal agent. Atropine is it's a supplementary agent. It's a carrier agent. Yani with neostigmine you give atropine. Why? Because neostigmine will cause bradycardia. So we are left out with three options. Okay? Neostigmine, physostigmine, and Sugammadex. Remember guys, physostigmine is not used. Why? Because it crosses blood-brain barrier. So two options are done, Neo and Sugammadex. The most commonly used reversal agent is always neostigmine, but nowadays newer generation reversal agent has come, that is called as Sugammadex, which is commonly used against rocuronium and vecuronium. What is the agent that is being used over here? Rocuronium. So your answer is what guys? Answer is Sugammadex. Okay, so remember guys, for reversing the patient from anesthesia, there are some signs in the patient that you see. What are the signs that you see? Okay, after surgery is done, you tell the patient to lift your head. If the patient is lifting his head for more than 5 seconds, that is the best sign. Okay, but the best overall sign is what? You take the train-off ratio. If it is more than 0.9, that means you can reverse the patient. So sustained head lift for more than 5 seconds and train-off ratio more than 0.9 is the best clinical sign for adequate reversal. What are the reversal agents that we use? Neostigmine is most common, but again, neostigmine is a cholinesterase inhibitor that will cause what? That will cause bradycardia. So what are we doing? What are we doing with neostigmine? With neostigmine, you either add atropine or glycopyrrolate. Okay? Pyridostigmine can be used, L-cysteine can be used, atrophonium can be used, but nowadays Sugammadex is used for rocuronium and vecuronium. It is a modified gamma cyclodextrin. Next guys, least potent inhalational agent among the following. When he's talking about inhalational agents potency, the answer should be potency of inhalational agent is directly proportional to the MAC. MAC is what guys? MAC is minimal alveolar concentration. So which is the least potent among over here? If someone is asking you, remember high MAC. Remember, MAC indicates potency. High MAC is equals to low potent, but MAC is always opposite to potency. Okay, and low MAC is equals to high potent. ठीक है, so always remember, ठीक है, high to low potent. The mnemonic is what, guys? For high to low potent, the mnemonic is universal HIST. HIST. ठीक है, H stands for halothane. ठीक है, I stands for isoflurane, S से sevoflurane, D से desflurane. ठीक है, you can add a small m, it becomes MHISD. M stands for methoxyflurane, which is the most potent, but again we are not using it. That's why just remember universal mnemonic HISD. If you remember this potency mnemonic, na, most potent or least potent, you can easily remember the fastest to slowest acting. If someone asks you the fastest to slowest acting inhalational agent, it will come in the opposite direction. Opposite direction of this mnemonic. DSIH. We'll come to it later. So anyways, first solving the MCQ, guys. Slow down. I cannot slow down, guys. Guys, how's my, like, is the pace fine or not? If I slow down and all, it will be available on YouTube. You guys can repeat and you can listen. How's the pace? First, tell me, how's the pace? Is it fine or I have to go more slow? It's not a full-fledged session on anesthesia, guys. It's a rapid review session. Okay. Right. So anyways, potency depends on what? MAC. So high to MAC means what? High MAC is equals to low potent and low MAC is equals to high potent. High potent. So I was telling you to remember that mnemonic, right? So answer for this is what? It is desflurane, right? So I told you potency ka opposite. Remember, if you remember this mnemonic, I told you that fastest to slowest acting inhalational agent will be coming in the opposite direction. But what determines the speed of inhalational agent? Blood gas coefficient. Blood gas coefficient indicates the speed of onset. So now you have to answer, guys. Fastest acting inhalational agent among the following: isoflurane, sevoflurane, desflurane, halothane. Come on. If you want to answer, again I'll write what? MAC mnemonic. High MAC to low MAC mnemonic was HISD. Okay, blood gas coefficient indicates fastest to slowest, so it will be DSIH. So which is the fastest among all, guys? It would be desflurane. Desflurane. Okay, blood gas coefficient indicates the speed of onset and recovery. Is it clear? So D stands for desflurane, S stands for sevo, I stands for iso, H stands for halothane. Next, guys. This capnograph depicts what condition? Come on, guys. What does this capnograph depicts? Come on. What's the answer for this? This capnograph is depicting. Normal capnographs look something like this. Okay, this is the normal capnograph. This capnograph looks like shark fin. Okay, even though very. Okay, this is shark fin. Even my shark is very bad. So you need to remember shark fin capnography is indicative of bronchospasm. Now guys, look over here. Capnograph indicates what? For capnograph is the surest sign to confirm intubation. That is the best confirmatory test for intubation. Capnograph comes in 4 phases, guys. Okay, just look over here, 4 phases. The first phase is called as inspiratory baseline. Inspiratory baseline. Okay, the second phase is called as expiratory upstroke. This is the second phase of capnograph, which is called as expiratory upstroke. The third phase is called as alveolar plateau. And the fourth phase is called as inspiratory downstroke. Inspiratory downstroke. Okay, these are the 4 phases of capnograph. Just look over here. Between phase 2 and phase 3, one angle is there alpha. Phase 3 and phase 0, one angle is there beta. Capnograph is measured at this angle. Capnograph is measured at this angle. Yani basically the exact value of 35, normal capnograph value is 35 to 45 centimeter, 35 to 45 mm of Hg, which is measured at beta angle. Now there are different forms of capnography, guys. So once you have intubated, you will see a normal capnograph like this. But if you see a flat line, yani ki you have intubated but you see a flat line, there is no graph coming like this, then what does it indicate? Flat line indicates what? Either you are in the esophagus, okay, you will get a flat line, or either you are in the trachea but still you get a flat line. The patient might develop, after intubation, patient have developed cardiac arrest. In both the cases, you will see a flat capnography. In case of accidental extubation also, you will see a flat capnography. Flat capnography in these conditions. If you see shark fin, we have already discussed. In bronchospasm, you will see shark fin capnography. Next, guys, look over here. If you see sudden fall of capnography, just look over here. Capnograph was going like this, and suddenly it falls. Sudden fall in capnography is seen in condition of venous air embolism. The murmur that you see over here is Millwheel murmur. Okay, that is the next capnograph. Next, if you see that your capnograph was coming normal, but suddenly you see a notch developing in your capnograph. Notch developing in your capnograph. Come on, guys, what does it indicate? Notch developing. Initially it was normal, but suddenly you see a notch developing. That means patient had started breathing spontaneously. Return of spontaneous breathing, you will see a notch capnography, Curare notch. What is the next thing that we need to do? Next is you need to give the top-up dose of muscle relaxant. Next step is you need to give a top-up dose. Next, in case of hyperventilation. Okay, in case of hyperventilation, what is the capnograph, guys? If you increase the respiratory rate, you will see a capnograph. Yani carbon dioxide is washed off and you will see a capnograph like this. Carbon dioxide was washed off. In case of hypoventilation, carbon dioxide accumulates and you will see a capnograph like this. Okay, this is the different capnographs that we need to remember. Okay, next, guys, during induction, a 50-year-old patient with rheumatoid arthritis develops cannot intubate, cannot ventilate scenario. A very, very harsh nightmare for anesthetists. Cannot intubate, cannot ventilate scenario. Come on, guys. What is the next step? Cannot intubate, cannot ventilate, CICV. Immediate answer should be what? I'll cut open the trachea, sir. Either by needle or either by surgical. I cannot go for repeated laryngoscopy. Yani cannot intubate, cannot ventilate means it is already, you have tried all the things. All the things. Then you have declared it. Okay. So answer is what? Transtracheal jet ventilation or surgical cricothyrotomy. That is the best scenario. Now, guys, remember, in case of difficult airway, okay, in case of anticipated or unanticipated, we are going for DAS guidelines. Plan A, Plan B, Plan C, Plan D. Plan A is what, guys? I'll try for normal intubation. While I try for normal intubation, always remember, give your best attempts. Go for 3 best attempts. If 3 best attempt fails, then you go for Plan B. Plan B should be what? Always, guys, aim should be what? You should ventilate the patient. I have seen many anesthetists taking on their ego, saying like doing what? They go for Plan A only. One intubation is failed, second failed, third failed, fourth. They are not concentrating what is happening to the saturation. So if Plan A fails, ego, leave it aside. It can happen with any anesthetist. Then what you need to do? Your aim should be, I should ventilate the patient. How? By putting an LMA. After putting an LMA, 99% patient will be able to ventilate. But in some bad scenarios, you are not able to ventilate. Yeah, okay, your Plan B also fails. After putting an LMA also, it fails. Then you need to go for Plan C. Plan C is what? You call one more person and tell what? We'll go for 2% technique of ventilation. Okay? If 2% technique also fails, then you have to declare CICV, cannot intubate, cannot ventilate. In that scenario, you should either go with needle cricothyrotomy or you should go with a scalpel cricothyrotomy. Scalpel cricothyrotomy. Okay, that is Plan D. So Plan A is tracheal intubation, Plan B is LMA. If LMA fails, 2% technique. If 2% technique fails, then Plan D. Okay. So remember, guys, tracheostomy, when you are putting whether it is a tracheostomy tube or whether it is a normal endotracheal tube, what is the function of the cuff? The function of the cuff is it provides seal for ventilation. Apart from that, it prevents aspiration. There is no risk of aspiration and no risk of leakage, and stabilizes the endotracheal tube. That is the function of the cuff. Function of cuff. Okay. We'll discuss something about normal intubation, guys. Normal intubation, if you want to do, what is the position required for normal intubation? We keep the patient in what position? We keep the patient in a flex, we keep the patient in the sniffing morning air posture. Sniffing morning air posture means where is the flexion and where is the extension? Flexion is at the cervical spines and extension is at the atlanto-occipital joint. Atlanto-occipital joint. Okay. After giving this sniffing morning air posture, you take a laryngoscope. There are two types of laryngoscope blades. One is called as Mac, that is curved blade. Other is Miller, Macintosh and Miller. Miller you're using pediatric. Why? Because they're having a large epiglottis. You take and you put it. That is for normal patient. If the patient is obese, what is the position? This is the rammed up position used for obese. So anyways, we have introduce the laryngoscope. Once you introduce the laryngoscope, you lift the tongue and you will see what? You will see the laryngeal aperture. Based upon the aperture appearance, there is a classification given called as Cormack-Lehan grading. Grade 1 यानी कि all, यानी कि you are able to see the laryngeal aperture clearly. Grade 2 means only posterior wall is visible. Grade 3 means only epiglottis is visible. And grade 4 means epiglottis is also not visible. That is grade 4 Cormack-Lehan. So anyways, guys, we also need to remember some of the points, which is the narrowest portion of adult airway. It is glottic opening, and in child airway, it is a subglottis. Okay. Next, a patient under anesthesia develops unexplained jaundice and elevated liver enzymes after 1 week of exposure to a volatile agent. Which drug is most likely responsible? So guys, remember, after exposure to one inhalational agent, patient might develop hepatitis or any liver problems. What is that drug called as, guys? It is the halothane. यानी कि hellfire, red in color, so red color vaporizer, halothane. When we are discussing about halothane, remember guys, always remember halothane. If someone asks you, answer should be 4 H's. What are the 4 H's of halothane? Just look over here. Halothane will cause what? Remember, in our patient, if you repeatedly use halothane or give halothane for a long time, patient will develop an hepatitis, which is called as halothane-induced hepatitis. But apart from hepatitis, what else it can cause? First H of halothane, you have to remember, halothane heart disease means what? Halothane is contraindicated in heart disease. Why? Because it can cause arrhythmias and it can cause hypo and bradycardia. How will it cause arrhythmias? Why? Because it will, if at all with halothane you are using some catecholamine, it can cause arrhythmias. Next H of halothane is hepatitis. Halothane repeated exposure can cause hepatitis. Next is what, guys? Halothane can cause hyperthermia. Which hyperthermia we are talking about, guys? We are talking about malignant hyperthermia. And last H of halothane is, halothane has two maximums. What maximums are we talking about? Maximum bronchodilation and maximum muscle relaxation. Even though halothane is an inhalational agent, it can cause some muscle relaxation also. Even though halothane is causing maximum bronchodilation, still we are not using this as for bronchial asthma. Why? Because it will cause some airway resistance. It is the second best agent for bronchial asthma. Best agent is sevoflurane. Okay. Next, guys. In which following condition LMA insertion is contraindicated? LMA, first of all, is a temporary airway or permanent airway. Always remember, LMA, laryngeal mask airway, is a temporary airway. It is contraindicated in which? It is given in short duration surgeries. It is given for difficult airway. We have discussed now. First, in difficult airway, if normal intubation fails, you go for LMA. In pediatric squint surgery, you can use LMA. But if there is a blood in the oral cavity, don't use LMA. You are pushing the blood in the lungs. Okay, so LMA is contraindicated. Blood in the oral cavity or tumor in the oral cavity. Now, guys, remember there are some generations of LMA. First generation and second generation. It is pretty simple, guys. First generation means only one port is there. Second generation means two port, one tracheal as well as esophageal for deflation of stomach. So LMA, remember classification. First generation, this is LMA classical. This is LMA flexometallic. This is Cobra LMA, and this is Ambu Aura 40, which is a first generation. All are having only one port. If you add one more port, it becomes second generation. That is LMA ProSeal, Supreme, iGel, Slippa and Ambu Gain. All are having 2 ports. Next, 60-year-old patient, COPD patient, conscious, coherent, having respiratory distress, is receiving oxygen through HFNC, but still oxygen is not improving. What is the next step? यानी कि you are giving the patient oxygen through the high flow nasal cannula, but saturation is still low. What you will give? Remember, nasal cannula was the first option. HFNC, if you are using, that means what? You have already tried nasal cannula, face mask, and other things you have already tried, NRBM. Now, what is the next thing? If high flow nasal cannula doesn't work, what do you need to do? Very good. You need to go for NIV. NIV means what? Non-invasive ventilation. Very, very important, guys. The main thing over here is patient is conscious, coherent. Very, very important. Remember, non-invasive ventilation. In ventilation, there are two types. There is invasive and non-invasive. For non-invasive ventilation, the main prerequisite is what? Patient should be conscious, coherent, as well as empty stomach. Why? Because if at all patient is, empty stomach is not that important, but conscious, coherent is very important. If he is semi-conscious and you put him on NIV, he will aspirate. Okay? In NIV, there are two modes, guys. One is called as CPAP, which is used for mild to moderate COPD cases, whereas for severe COPD, we use BiPAP. BiPAP यानी कि two things. It will the BiPAP यानी कि it will deliver the gases by inspiratory and expiratory, a higher inspiratory and a lower expiratory pressure. So remember, guys, this is regarding the ventilators. But remember, if the patient is semi-conscious or drowsy, you never use the NIV. Next, which inhalational agent is likely to cause second gas effect? It is pretty simple, guys. Second gas effect. Second gas effect means what? First of all, remember, second gas effect means if you are using halothane, and if you add one inhalational agent with halothane, it will increase the concentration of halothane only. What is that, guys? Nitrous. Remember nitrous. Remember, nitrous is a supplementary or supporting gas, not a main inhalational agent. Why? Because it's having a high MAC, that is a low potency. That makes it least potent. So remember, guys, nitrous oxide. Nitrous is used as a supportive gas. Supportive gas or carrier gas. Okay? यानी कि with other inhalational agent you use it. What's the color of nitrous cylinder? Very, very important, guys. Nitrous is stored in Neela cylinder. Neela यानी कि blue color cylinder. You store nitrous in blue color cylinder. It is a very good analgesic. Okay? It is avoided in what? It is avoided in closed loop surgeries. Why? Because it usually expands the air containing cavity. Closed loop surgery, nitrous is avoided. Right? Now, nitrous, when you give, the patient will have diffusion hypoxia as well as second gas effect. What is diffusion hypoxia, guys? At the end of surgery, when you are cutting off the nitrous and all, what will do? Nitrous, due to its weight and all, it will displace the oxygen. Okay? It will displace the oxygen and patient becomes hypoxic. So what we do is, at the end of surgery, when we are cutting nitrous, we give 100% of oxygen for 5 minutes so that diffusion hypoxia can be prevented. Second gas effect means I have already told you. Next, 6-year-old child is undergoing tonsillectomy. You plan to give him general anesthesia. Okay? But the child is not allowing you to put an IV cannula. Hence, you decide inhalational induction, which is the inhalational agent used for induction. Remember, guys, normally, whether it is children or adult, you go for IV induction. But if IV induction is not possible, inhalational. In inhalational as well as child is given, then child को सेवैया खिलाओ, yellow color सेवैया. Why? Because sweet रहेगा. So what you need to remember, what's the answer over here? Sevoflurane. Sevoflurane is the only is the only inhalational agent which can be used for induction as well as maintenance purpose. Okay. It is the inhalational agent of choice in what all conditions? In bronchial asthma. Okay. In children. In daycare surgery, it is an inhalational agent of choice, as well as in neurosurgery, it is an inhalational agent of choice. But it is avoided in renal patients. Why? If you give sevoflurane in low flows, यानी कि very low flow of oxygen, low flow of nitrous, and you give sevoflurane, sevo will react with soda lime to form a nephrotoxic compound, which is called as compound A or olefin, which is nephrotoxic. Hence, it is contraindicated in renal failure. There is one more agent called as Isoflurane, guys, remember iso is commonly used in cardiac surgery, can be safely given in renal patient, but the side effect of isoflurane is what? It can cause coronary steal phenomena. Coronary steal phenomena, but again in animal studies. Coronary steal phenomena in animal studies. Okay. Next. What is the control variable and volume control mode? Guys, remember in ventilator modes, I'll not go into deep. You just have to remember which is a control variable. Control variable means what is the variable that you are controlling in volume control. It is the tidal volume. If you control the pressure, if the control variable is pressure, then it becomes pressure control mode. Okay. Now guys, remember which mode of ventilator will act like this. Come on guys, be fast. Which mode of ventilator will say kabhi kabhi lagta hai apuni bhagwan hai? Why? Because it is controlling all the things. Remember, in ventilator, two things should be in control. One is the tidal volume, other is the pressure. Okay? If you are controlling the volume, it becomes volume control. If you are controlling the pressure, it becomes pressure control. But remember guys, one mode of ventilator is there which controls all two things. That is called as CMV mode. That is continuous mandatory ventilation. Now guys, remember continuous mandatory ventilation. What is the control variable? Both tidal volume and pressures both are controlled by the ventilator. There is no control variable. Is trigger breathing allowed? Remember guys, just remember, patient met with a road traffic accident. He's not breathing. Come to the casualty. He's intubated, sent to the ICU. When he's sent to the ICU, you have to keep him on ventilator. First mode I will keep is CMV. I will tell the ventilator, please control that volume as well as pressure. I don't want the patient to be breathing. So is trigger breathing allowed in CMV mode? No. So if trigger breathing is not allowed, what will I do? I have to heavily sedate the patient. I have to heavily sedate the patient. And due to this, what is the side effect of CMV mode, guys? Now the patient is totally dependent on the ventilator. Now patient becomes lazy, tells the ventilator, you do my work. Why should I breathe? So what will happen to his muscles? Muscles become atrophy. The most common side effect of this is atrophy. Okay? With CMV mode, you will see atrophy of the muscles. Next, guys. ACMV. Next mode is ACMV. In ACMV, there are two things: volume control and pressure control. In volume control, what is the control variable? Guys, control variable in volume control is tidal volume. Pressure control variable is pressure. Trigger breathing, is it allowed? Yes. In ACMV mode, you are assisting the patient. So trigger breathing is allowed. Due to this allowance of the trigger breathing, sometimes patient will have asynchrony, sometimes patient will have respiratory alkalosis, sometimes patient will have respiratory acidosis. Okay. Okay. Next, if the patient is doing well on ACMV, I will tell the nurse, now the patient is doing well. Now we will slowly cut down to other mode, that is spontaneous mode. In spontaneous, you are having SIMV mode and pressure support mode. SIMV mode and pressure support mode means what? Basically, you are allowing the patient to breathe. You are just giving one breath. Yani ki ventilator is giving one breath and then patient is taking his one or two breath. Then if the ventilator feels the patient is not taking breath, that again ventilator is giving one more breath. But due to that, what will happen? Just look over here. As the ventilator is giving breath, and you can see ventilator, when it is giving breath, it is giving a good tidal volume. Patient tidal volume is not that much. Due to that, what will happen? Patient develops hypoventilation and might develop respiratory acidosis. Might develop. But if the patient is breathing well, he might not develop it. Okay. So remember, main things that you need to remember is CMV mode. Everything is controlled by the ventilator and patient becomes dependent, and due to that, patient might develop atrophy. There might be atrophy of the muscles. Okay. Next, during central line insertion, the patient develops sudden breathlessness and hypotension. Come on, what's the answer for this? Sudden breathlessness and hypotension. What's the answer for this? Hypotension and tracheal shift to the left side, absence of breath sound. Guys, remember, this is basically giving you a clinical diagnosis of a thing called as pneumothorax. Pneumothorax. Okay? Remember, pneumothorax. and he is becoming hypotensive, that means it could be, it is mostly tension pneumothorax. When clinically patient is giving you so much of hints and all, why will you go for chest x-ray? Chest x-ray is not done. Okay, re-intubation. Why will you go for re-intubation? Yani patient was intubated. Why will you go for re-intubation? If you re-intubate also, it will increase the intrathoracic pressure. You won't go for re-intubation. IV fluids also you won't give. Remember, clinical diagnosis of pneumothorax is made. He has given you the signs. You go for needle decompression. Now, how will you go for needle decompression? If you are going for needle decompression, okay, you can go for second intercostal space from the mid clavicular line and insert the needle. Mid clavicular line, and you can insert the needle. Or you can go for fifth intercostal space from the mid axillary line and insert the needle. Mid axillary line, and you can insert the needle and relieve the pressure. Okay, that's regarding what? That's regarding the management. Okay, now guys, management of pneumothorax, immediate thoracostomy. Now, we were discussing about central line. Now, central line, when you are putting, what are the sites for central line? Central line mein just look over here. You can put central line in the internal jugular vein or the subclavian vein or the femoral vein. These are the common sites. Now, which is the most preferred, guys? Always remember, IJV is the most preferred. Which produces least chances of infection? Subclavian produces least chances of infection. Most chances of infection are seen with femoral. Okay, central line, there are many indications, guys. If you are giving inotropes, you can put central line. Good amount of fluids, TPN and all, you can put central line. Okay, next, a young male in trauma has hypotension and tachycardia. Which IV induction is regarded as the best IV induction? Come on, guys. Patient is having a BP of 70/40 in IV induction agents, which is the IV induction agent which can be given. If you give propofol, BP will become 50/20. Propofol decreases the, as propofol decreases the BP and heart rate both. Okay? If you give thiopentone, again BP becomes 50/30. Yani it causes hypo as well as tachycardia. You cannot give. If you give ethomidate, BP will be 70/40 only. Okay, can you give ethomidate? No, I want the BP to increase. So answer is what? Give ketamine. In shock-like conditions, you have to give ketamine. Now, something about IV induction agents. IV induction agents are used to make the patient unconscious. Now, in IV induction, there are two types: non-opioid and opioid. In 95% of the patients, we are using non-opioid. 5% of the patients whose ejection fraction is low, we make them unconscious by using opioid induction. In non-opioid, what are the induction agents? Thiopentone, propofol, ketamine, and ethomidate. So just look over here, guys. Thiopropofol, ethomidate usually acts on the GABA receptors, whereas ketamine acts on the NMDA receptors. Ketamine, apart from ketamine, what in the anesthesia, what are the other drugs that acts on the NMDA receptor? Xenon and nitrous. Okay. So anyways, we are giving an IV induction agent. And I told you we are discussing about what? Ketamine. So ketamine is which derivative? Ketamine is a phencyclidine derivative which blocks the NMDA receptor. Phencyclidine derivative which blocks the NMDA receptor. Nowadays, there is a psychoactive drug called as S-ketamine, which works as a rapid-acting antidepressant, which is given intranasally, S-ketamine. Okay. So anyways, ketamine, what we need to remember, guys, two things. Ketamine effect on various systems. What systems? The basically CNS, respiratory, cardiovascular, muscles. You always need to remember ketamine is the best friend of all systems and enemy of central nervous system. Ketamine is the best friend of all other systems, but enemy of CNS. Okay? Why am I telling best friend of all systems? Regarding respiratory, ketamine causes bronchodilation. Hence, it is the IV induction agent of choice in asthma. Okay? Ketamine, what does it cause to the cardiovascular system? It increases the BP and pulse rate. Hence, it is the IV induction agent of choice in shock. But remember, it acts on the myocardium and it is a cardiodepressant. Hence, it is contraindicated in ischemic heart disease. You can give ketamine in cyanotic heart disease, but contraindicated in ischemic heart disease. Next, ketamine increases the muscle tone. Yani it is a best friend of all systems, but enemy of what, guys? Enemy of head. Okay, CNS. Yani ketamine, when you give to the patient will have patta se head shot. as said by Mr. Dynamo. So look over here. Why am I saying ketamine is the worst enemy of CNS? Just look over here. Ketamine increases the intracranial pressure. So hence it is contraindicated in head injury. Ketamine increases the intraocular pressure, contraindicated in glaucoma. Ketamine causes epilepsy, contraindicated in epileptic patient. Ketamine causes hallucinations, hence contraindicated in schizophrenia. So all in all, ketamine is a worst enemy of CNS, and any hallucinations caused by ketamine can be managed by midazolam. Okay. Next, during general anesthesia, an intern accidentally connects a brown cylinder instead of white shoulder black cylinder to the yoke. And he has connected a brown cylinder. The patient develops desaturation shortly after induction. What was the gas likely connected by mistake? Come on, guys. Come on. Which was the gas? Brown cylinder he has connected. That means he has connected helium cylinder. Okay? Instead of what should have been connected? Oxygen. Okay? So helium color is brown in color. So remember, guys, in oxygen, in the machine, this is the anesthesia machine which are having many parts, starting with the cylinder. The cylinder is made up of what material? It is made up of molybdenum. But these are non-MRI compatible. MRI compatible cylinder is made up of titanium and aluminium. There are different sizes of cylinder, sizes A till J. Most commonly uses size E cylinder. Now, guys, color coding is given so that you can see the color and tell this gas is present in the cylinder. So look over here, guys. What is the color coding of the cylinder? This person resembles what cylinder? Okay? Yani ki he's having black body and white shoulder. What cylinder, guys? He represents what cylinder? Oxygen cylinder. Oxygen. And he looks like a bodyguard. But he's a bodyguard. So remember, oxygen is a bodyguard to us. So it will be stored in a black body, white shoulders. Okay? So oxygen it is. Black body, white shoulder. Whereas air cylinder means what? Opposite of oxygen. It is white body, black shoulder. In some countries, we use air cylinder as gray body as well as black and white shoulders also. Okay. Nitrous. Nitrous means it's very simple. Nitrous yani ke neela. Neela means what, guys? Blue color cylinder. Okay. Entonox means what? It's a mixture of nitrous and oxygen. That is, it is blue body, white shoulders. Blue body, white shoulders. Carbon dioxide, what is the color of the carbon dioxide cylinder? It is gray color cylinder. Carbon dioxide is gray color cylinder. Okay. Now, guys, remember, to the cylinders, there is pipeline also. Pipeline in central supply, it will come. Those pipeline colors also they are asking. What is the color of pipeline? It's very simple, guys. Just remember the shoulder color, that is the pipeline color. Oxygen, what is the pipeline color? Shoulder color of oxygen is white. So white pipe. Okay. Air, black. Okay. Nitrous, blue. And whereas vacuum is also one pipeline, which is what in color? Vacuum V starts. So it looks like Y. So yellow color. Yellow color. Okay. That's regarding the pipelines. Next, guys. 60-year-old male with ischemic heart disease is scheduled for hernia repair. Which IV induction agent is safest? Come on, guys. Be fast. Propofol, thiopentone, ethomidate, and ketamine. Which is the safest over here if the patient is having ischemic heart disease? In ischemic heart disease, you don't give any agent that will cause sudden fluctuation in BP, whether increase or decrease in BP or whether increase or decrease in heart rate. You have to give an agent that usually maintains BP and heart rate, that is ethomidate. But this ethomidate comes with a side effect. When you give long-term infusion of ethomidate, what will happen? Long-term infusion of ethomidate can cause adrenal suppression. Adrenal suppression. There is one more agent, IV induction agent called as methotrexate, which is commonly used for ECT, guys. ECT is electroconvulsive therapy. Okay. Next, 30-year-old patient is posted for lipoma excision on the hand under general anesthesia in a daycare setup. Anesthetist plans for TIVA. TIVA is nothing but total intravenous anesthesia. That means you are giving general anesthesia without using inhalational agent. That is called as TIVA, which is the induction that is used in TIVA. The answer is what, guys? Answer is propofol. Propofol is the IV induction agent of choice in TIVA. Propofol. When you see propofol, it is a milky white solution which is made up of egg, lecithin, and soy. Egg acts as an emulsifying agent. Remember, once you open the propofol vial, use within 6 hours, otherwise it gets contaminated. Propofol, when you give, patient will complain of pain. It is the most painful IV induction agent, followed by ethambutol and thiopentone. These are also painful. But the most important point of propofol is what? Propofol is used as an IV induction agent of choice for daycare surgery. Now guys, be focused on daycare surgery. If the patient is posted for daycare surgery, will you put an endotracheal tube or LMA? I will put an LMA. So propofol is an IV induction agent of choice for LMA insertion. In daycare surgery, I will use TIVA. So propofol is the IV induction agent of choice for TIVA. Okay? In daycare surgery, I don't want my IV induction agent, I want my IV induction agent which is anti-allergic. So propofol is having what property? Anti-allergic property as well as anti-emetic property. Anti-emetic property. Apart from that, in daycare surgery, I want my drug which is having no effects on the no side effect on liver, and also propofol can be safely given in liver disorder. Okay? Propofol does not have any risk of acute intermittent porphyria, and propofol can be safely given in malignant hyperthermia. So with daycare surgery, you can remember all these points. Propofol, this you have to remember, guys. This you have to remember. Okay? Daycare surgery, usually for short duration surgeries, we post the patient for daycare surgery. Short duration means minor surgeries, and short duration means 2 to 3 hours of duration. You can post where you are expecting least blood loss. You can post if the patient's home is nearby. You can post in daycare surgery. Okay, ASA 1, 2 and ASA 3, which is control, you can post for daycare surgery. Okay guys, this is regarding what, guys? Propofol. All things of propofol you have to remember. Next, 65-year-old COPD patient is being ventilated through Mapleson circuit. Which circuit is most efficient for spontaneous ventilation? Come on, guys. Remember, for Mapleson circuit, you always need to remember SACD. Okay, SA means what? For spontaneous ventilation, A circuit. For controlled ventilation, you have to use circuit D. Circuit D. So what's the answer over here? For spontaneous ventilation, circuit A should be used. Okay. So Mapleson A circuit. Mapleson A circuit is also called as Maggle circuit. It is a circuit of choice for spontaneous ventilation. Mapleson D circuit, it is also called as Bain circuit. Okay? It is a circuit of choice for controlled ventilation. Controlled ventilation. In order to prevent rebreathing in Mapleson D circuit, fresh gas flow should be 1.6 times the minute volume. Okay? Mapleson E circuit is a bagless and a valveless circuit. A circuit without bag and a valve. Bagless and valveless circuit. Okay? But this was modified by a guy called as Jackson Rees, who added a bag. And this Jackson Rees type F circuit, it is a circuit of choice for control as well as spontaneous ventilation in pediatrics. In pediatrics, very important. Control as well as spontaneous ventilation in pediatrics. But guys, remember, these are semi-closed Mapleson circuit. If you are going with closed circuit means there is no pipe. Directly that pipe is connected to a machine or connected to a chamber that will absorb carbon dioxide. In semi-closed circuit, carbon dioxide goes out with the help of expiratory valve. In closed circuit, there is no expiratory valve. All the carbon dioxide goes to this chamber. What is this chamber, guys? It is soda lime chamber that absorbs. Soda lime chamber, 80% is calcium hydroxide, 16% is water, 3% is sodium hydroxide, which is a main component. The major component is always calcium hydroxide, and 1 to 2% is silica. Silica and potassium usually improves the hardness of the granules. Now, when you are using soda lime, some agents are contraindicated or avoided. What are agents are contraindicated, guys? C stands for chloroform is or avoided with soda lime. T stands for trilene is avoided, and S stands for sevoflurane. Why? Because if you give sevoflurane, remember CT scan. Always remember CT scan is avoided with soda lime. Okay? If you give trilene and all, it will react with soda lime and trilene will form phosgene, dichloroacetylene, that will cause ARDS. Sevoflurane, if you give with soda lime in low flows, will cause compound A. Okay, that is regarding soda lime. Soda lime is a carbon dioxide absorbing chamber. If soda lime is not there, instead of soda lime, we can use barrelime. But remember, when you're using barrelime, 3 agents are avoided with barrelime also. D stands for desflurane, I stands for isoflurane, E stands for enflurane. If you use these agents with barrelime, they react with barrelime to form carbon monoxide, and maximum carbon monoxide chances are seen with desflurane. With what, guys? Desflurane. Next, guys, coming to the last topics, CPR. Just look over here. 75-year-old patient collapses in the ward. He is unresponsive, apneic, has no pulse. What is the next best way? Unresponsive, yani ki I have already checked the response. I have already checked the breathing. I have already checked the pulse. Yani ki normally when a person collapses, first is you check the response. If there is no first is scene safety. After scene safety, you check the response. If no response, you call for help. If after calling for help, you check for the pulse as well as breathing. If there is no pulse, no breathing, you go for a next step. What is that? You start high quality chest compressions. High quality chest compression. So remember, the first step is scene safety. Second is check for the response. Yani ki SCCS. S is scene safety, C is check response, C is call for help, C is check for pulse. Check for pulse means in adults, carotid pulse, and in infants, brachial pulse. Okay. And if there is no pulse, no breathing, start your CPR. When you are starting your CPR, are you going for ABC or you are going for CAB? You always go for CAB. Okay, CAB. CAB is nothing but compressions. You start with then airway, then breathing. And D is also added, that is defibrillation. Okay, defibrillation. Now guys, when you are giving compressions, how many compressions should be there? The number of chest compression should be what, guys? The number of chest compression should be, right, 100 to 120 compressions per minute. The depth of chest compression should be 5 to 6 centimeters or 2 to 2.4 inches in case of adults, whereas in infants it should be more than it should be 1.5 inches or 4 centimeters. Whereas in children who are more than 1 year, 2 inches of chest compression or 5 centimeters or 1/3 of the anterior posterior diameter. What is the ratio of compression? 30:2. Okay? It doesn't mean 1 minute 30:2. In 1 minute, 4 sets of 30:2 you have to give. And in between, you have to allow the chest recoil also for better perfusion. Okay? Next, during BLS, a single rescuer scenario for 6-year-old child. What is the correct compression to ventilation ratio? Come on, guys. During basic life support, if there is a single rescuer in a 6-year-old child, how many compression should be given? Remember, guys, single rescuer means 30:2. If more than one rescuer in children, you go for 15:2. Why? Because children are having a higher respiratory rate. So single rescuer means answer is always what, guys? 30:2. So the ratio, remember, if it's a single rescuer in adults, the ratio is 30:2. In pediatrics also same, 30:2. Whereas if it is more than one rescuer in adults, again it is 30:2, but in pediatric cases 15:2 you have to give. If at all during giving chest compression, if you have put an advanced airway, that is LMA or endotracheal tube, then you don't need to stop for 2 rescue breaths after 30 compression. Give continuous compression. Tell your friend every 6 seconds you have to give 1 rescue breath. That becomes how much, guys? 10 rescue breaths per minute. In case of pediatrics, 20 to 30 rescue breaths per minute. In newborns, the ratio of compression to ventilation is how much, guys? 3:1. Okay, 30:2 by 30:2. In some of my video, I have by mistakenly told 30:1. I have clarified also in the comments. Okay. Anyways, guys, when is this position used? Come on, guys. When is this position used? This is the recovery position, making the patient lateral. When the patient is having pulse, when the patient is having breathing, but he is unresponsive, you keep the patient in recovery position. Okay, pulse and breathing is present. Next, guys, a 40-year-old man has pulseless VT after 3 rounds of defibrillation. CPR, the same rhythm persists. What is the next step? Come on, guys. What you should do? Yeah. In neonates, it is 3:1. Just look over here. What we need to do? Remember, after 3 rounds of defibrillation, if it is still continuing, defibrillation is a type of you're trying to revert the rhythm through electricity. If it is not happening electrically, give chemical defibrillation. Chemical defibrillation is what? With the help of drug. If after 3 shocks you give amiodarone 300 mg IV, after 3 shocks you give amiodarone. After 2 shocks, you start adrenaline. And once you start adrenaline, irrespective of the rhythm and all, every 3 to 5 minutes, you need to repeat the adrenaline. Okay. So guys, remember the cardiac arrest algorithm is what? Basically, remember, if the patient is having if the patient is having if the patient is having a shockable rhythm. What is shockable rhythm, guys? VT or ventricular fibrillation, a scribbling rhythm. Then what you need to do? You need to give shock. You need to continue CPR. Then after 3 shocks, you are giving amiodarone. After 2 shocks, you are giving adrenaline. So this is the sequence. But if the patient does not have a shockable rhythm, if it is a patient is having a flat line or asystole, then what you need to do? Then you need to go for just continuing compressions and giving adrenaline, and you have to rule out 5 Hs and 5 Ts. If the patient is having shockable rhythm, after 3 shocks, you start amiodarone and you have to rule out 5 Hs and 5 Ts. Now guys, just look over here. If the patient is having a shockable rhythm, we are using defibrillator. What are the defibrillator that we use? Manual defibrillator. There are 2 phases, monophasic and biphasic. In monophasic, the joules that we use is 360. In biphasic, it is 120 to 200 joules. So I told you, if the patient is having a non-shockable rhythm, what you need to do? You need to start compressions and give adrenaline. Give adrenaline as soon as possible, 1 milligram, and repeat it every, how much, guys? Repeat it every 3 to 5 minutes. Okay? And then you need to rule out 5 Hs and 5 Ts in case of non-shockable rhythm. Okay? In case of shockable rhythm, after 3 shocks, you have to give amiodarone and rule out 5 Hs and 5 Ts. What are the 5 Hs and 5 Ts? 5 Hs are nothing but hypoxia, hypovolemia, hypothermia, hydrogen ion acidosis, hypo and hyperkalemia. That is 5 Hs. 5 Ts are what? 2 Ts related to heart, 2 Ts related to lungs. 2 Ts related to heart are what? Tamponade, that is cardiac tamponade or coronary thrombosis. Coronary thrombosis. 2 Ts related to lung are what, guys? One is tension pneumothorax. Tension pneumothorax or pulmonary thrombosis. And 1 T is what, guys? Toxin. Toxin, okay? Right? So guys, remember, if you are performing CPR in a very good manner, when all these things, remember the chain of survival, when this chain of survival is performed, it increases the chances of survival, okay? So remember, initially we were using this chain of survival. Now in the chain of survival, the last thing that is added over here is recovery. Recovery is added. If all things are performed in a line-wise fashion, then chances of survival are very, very high. This was regarding the CPR, guys. Okay, so basically this was regarding anesthesia, guys. This was a very rapid session. Why it was rapid? Because it is just a revision for you. Okay, in detail and all, you have to go through the notes and all, but I tried to cover almost all the things. Okay, almost all. Once you are reading this notes and all, you don't have to go for any previous MCQs and all. You just solve this. You just go through the notes. You will be done with anesthesia. Okay, all the very best, guys. Do very well. Keep your confidence high. Okay, keep your confidence in that manner that you are going to crack this exam. Don't let the feeling that you can or cannot know. Go with a good confidence and crack this exam. Okay. Thank you everyone. Thank you. Hope to see you all on the other end. Okay, hope I guide you in preparing for INICT and NEET PG. All of you. Okay. Thank you very much. Thank you very much. right? If you're having any doubts and all, you guys know where to get to me. Okay, this is my Instagram ID. You can post your doubts. There is some time lag. There will be some time lag, but I will answer. Okay. Okay, guys. All the very best. All the very best. So it takes a very long time to cover topics. Yes, if you're starting now, it will take long time. But again, this is the LRR thing. You have to cover it. That is a must thing. Okay. Okay, guys. Now be stress free, and at least for anesthesia, be stress free and enjoy, guys. Okay. Bye. Take care. Yes, yes, yes. Yes, bhai. It is enough for FMGE. Yes. Okay. Bye. Thank you, guys. Bye.